Welcome to our SBH Fertility event. I have to make a clear statement. There is no one, and I mean no one in this community that doesn't need us at some point in time. You hear me? Whether it's a girl that's trying to get pregnant, is already expecting, going through a difficult pregnancy, going through a loss, went through a difficult delivery, postpartum, etc. We're all there. We're really there for their journey. That's what we're here for. We hold your hand from the beginning to the end. I call us 24/7 Hatzalah. I can tell you that we get phone calls all day and all night. I'm personally involved in it, and I can tell you that my phone is on, and all my coworkers, we answer every call all the time, whether it's text, whether it's phone. I mean, I'll be honest with you. Since my husband was a rabbi, we've even gotten calls on Shabbat where he had to answer very serious shailot about what to do. So we are here 24/7. There's nothing to talk about. And I have to tell you something else which is interesting, because I was there from basically the beginning. The amount of siyata d'shmaya that we have seen has been unbelievable. It's like the hand of Hashem is all over it, which has enabled SBH Fertility to soar the way it did. Not every organization gets this big, this fast in such a short amount of time. It's been incredible. And one of the key situations that have been coming up quite frequently, and unfortunately, it's a word that my kids say, "Ma, we never grew up with it, we don't even know what it is." The word anxiety. Unfortunately, it's all over the place. And now lately, through pregnancy and after, which really leads me to introduce, I would say, one of the greatest women in this area that I've ever seen. I am going to read you her bio. It is so long, bear with me. Devorah Enton, LCSW, PMH-C, specialized in reproductive and perinatal mental health with advanced training by Postpartum Support International, ASRM, and the MIST Foundation in Compassionate Bereavement. Devorah is a clinical consultant for Kinefayim pregnancy loss and a lead trainer for Postpartum Support International. Recently, they did a very nice job. They gave me big print. At my age, you need big print. They're recently launching their perinatal loss advanced training as an adjunct professor at Warsaw School of Social Work. She developed and teaches maternal mental health. Devorah is the program director of JFCS, Philly Safety Kid Initiative, coordinating child abuse prevention programming across all Jewish day schools in Philadelphia, a graduate of Counsel for Relationships, intimacy therapist, postgraduate training. Devorah maintains a group private practice in Philadelphia and consults and presents nationally about mental health and supporting those in struggle. Check out her podcast. I have to tell you something. On a personal level, I have seen her in all my years. I've never, ever met anyone like her. She's brilliant. She has clarity that's a true gift. And she's always right. I have to say, always right. Hashem should bless her with many more years to continue her help for Klal Yisrael. And please welcome Devorah.
Mrs. Haber, you're going to tell my kids that I'm always right, my husband that I'm always right. I'm just making sure. I'm going to ask you for that. You're good with that? Okay, just making sure. That's quite the introduction. Good morning, everybody. Thank you so much for hosting me. Really is a privilege. I actually have been a part of SBH and fertility almost from the beginning. And, I have never seen it. Mrs. Haber is correct. I have never seen an organization grow as quickly, as expansively, and as committed to excellence as the organization that you are here to support and are part of. So a tremendous yasher koach to all of you who are not only supporting it, but committed to it, who are benefiting from it. It's really, really unique and a magnificent thing to see. So may HaKadosh Baruch Hu continue to give us the ability to do this work, to continue to reach people who need support. So I want to talk to you a little bit about, we're talking about anxiety. It's funny how she said that her children never heard that word. I mean, I don't know how I would grow up without hearing the word, but we've called it something different. What do you think we called it when we were younger? What did we call it? We didn't call it anxiety. What did we call it? Nerves, right? She's a very nervous person. Another word, what do we hear? Older generation. Anybody think a little bit older than that? If it wasn't nerves, what other words would we use? Yell it out, because I'm old, I have no hearing. Tell me one more. Stressed. Excellent. She's so stressed. She's under so much stress. What about worry wart? Do you remember that one? Oh, she's such a worry wart, right? Ma, you're such a worry wart, right? We all have memories of calling those things we used to talk about. She had a case of the nerves and she was hospitalized, or she had a nervous breakdown, right? We all, the emotion, the experience of anxiety has not changed. How it's expressed and our language around anxiety definitely has changed. And I think that there's an idea in psychology, this idea of like, we have to name it to tame it. Are you familiar with that idea? That if I just have all these feelings and all these experiences and all these emotions, but I don't know what to call it, I might feel crazy. And I also might feel very alone. And I also might feel like I must be the only one who has this experience and nobody else experiences this at all. If you think about it, I think that's one of the greatest influences of social media, right? The world as presented on social media tells me that nobody else has problems like me. Or there's one or two people I follow who acknowledge that it's not as easy as it looks. Are we in agreement on this one? Right? And even if I convince myself, I know it's social media, I know they're just putting out like a profile out there and they're just putting out they're just trying to influence certain things, and I can convince myself all I want, but there's some part that's underpinning all of that still makes me wonder, is everybody else okay? And I'm not okay? Is everybody else like living this life that I dream of, but I'm not living that life internally? And I think that's one of the challenges we have. There's a lot of benefits to it in terms of access to resources and care and support. But there's a flip to that as well, of what we get, what is in front of us influences how we feel, influences how we perceive our lives and the world around us. So I want to start off, when we talk about anxiety in the reproductive years, I want to acknowledge that anytime there's a variation of hormones, anytime we're switching our hormones up or down, anytime there's that kind of level of change, we are at some level of added vulnerability. So some women are incredibly sensitive to hormonal change. Anybody know anybody like that? Don't talk about yourselves, but like anybody know anybody who might be like a little bit sensitive to hormonal change, right? When we were younger, we would say things like, oh, she's PMSing. Yeah? Okay. So I'm not talking just about like people I know, right? We all know people who are hormonally vulnerable. And so that actually has been proven, right? That scientifically, and studies have shown that when there's hormonal fluctuation that are natural or unnatural, we know that there's added vulnerability, and when there's vulnerability, there's risk for disruption or dysfunction. So vulnerability means added risk for functionality or dysfunction. So let me break that down for you a little bit. First and foremost, I think we got to name it to tame it. So I want to name what anxiety is, and also what it isn't. So anxiety, by definition, is anytime we're going to call something a diagnosis, it has to impact functioning. So I can have a very highly functional, successful person who's like, I'm just a worrywart, I'm anxious, like that's my baseline is anxious, but it doesn't prevent me from functioning. It doesn't prevent me from taking care of my children, going on trips, getting on an airplane, going away to camp. Like, I have anxiety, but I also have figured out a way to manage it and tolerate it. I'm okay enough, right? So we know that as functionality. The definition of anxiety from a diagnostic perspective is it has to impact our functioning. So we're thinking about things like significant rumination. That's a term that we use with anxiety. So my mind, think about it as the mind is always running. Very often women, I'm going to speak specifically to women, very often women are going to sleep at night. They don't have any trouble falling asleep. They're exhausted, but at 3 a.m, they're wide awake. Maybe they have to go to the bathroom for the 6th time, right? They're getting up, they're going to the bathroom, they come back into bed, and they're like, my mind can't stop running, right? So sometimes it's a matter of like, this is what I have to do tomorrow and the next day, and I forgot to take care of this, and I forgot to call that one back, and do you think it's too late to text them at 3 a.m? And like, that's the rumination that exists, but also rumination of worry. What if this happens? What if we're supposed to be going on vacation tomorrow. Guess what? We was on WestJet and they went on strike. So I could spend all night long ruminating on, I don't know if I'm going on vacation. Thankfully, they signed a deal. The mechanics are back from strike. Hopefully, we're going on vacation tomorrow. We'll see. So the plan is that I can be successful in falling back asleep saying like, you know what, I'm just going to deal with it in the morning. Or my mind begins to run all night long. What if this doesn't happen? What if the Airbnb is non-refundable? What if those mechanics are really tired because they've been striking all night long? And then what if they really don't check the plane the way that I really want them to check the plane, because they're the mechanics checking for the safety of my plane? That's rumination. Okay, rumination is where my mind goes into a loop over and over again, keeps me awake, keeps me distracted. Make sense? Okay, rumination. In addition is excessive worry. So part of my rumination, I'm not just ruminating over the good things in my life, I'm really ruminating on the things that I'm worried about. So that excessive worry, where my mind is looping around again and again with excessive worry around things that I maybe could be worried about, should be worried about, but also spending quite a bit of time worrying about those things. In addition to that rumination, that worry, this is all part of anxiety, very often we experience somatic symptoms of anxiety. Anybody want to name a few? You're going to have to yell really loud. Anybody want to name some somatic, meaning how I experience it in my body? Last night, tell you it again? Heart racing. My heart is pounding. Why is it pounding? I'm worried about something. What else? Sweating. Excellent. I'm suddenly breaking out into a sweat. What else?
Hard to breathe.
Hard to breathe. Excellent. What else?
Feel like you're gonna faint.
Feel like I'm going to faint. Excellent. Lightheadedness. Nausea. Excellent. Anything else? Just by the way, with nausea, it was really fascinating. I was working with a woman who was dealing with like a chronic nausea of pregnancy. We were questioning whether this was hyperemesis gravidarum, like where she had HG, like a diagnosis of severe anxiety in pregnancy. And then as I began to understand her and she began to understand herself, we realized that when she's highly anxious, she's vomiting. Once we got the anxiety under control with medication and therapy, she stopped vomiting. It was really remarkable to see. So sometimes maybe looking at something, is it vomiting? Is it representative of anxiety? There's another symptom I want to bring up, chest pain. How many of you are familiar with that? How many people have heard of people who end up in the ER, right? They're like, I'm for sure having a heart attack. And actually they're having a panic attack. So part of anxiety can be experienced in this like pressure in my chest. I know when I'm highly anxious, I actually feel it here. Anybody else feel it in their throat? Like, I think I for sure have thyroid cancer because I can't swallow, right? Some of us have that anxiety. Okay, I'm not the only one who experiences that. So that thickness of the throat, that feeling of like I can't swallow, I feel like something's stuck in my throat, chest pain, those are all experiences of anxiety. Somatic experiences. Just last night, I taught a class. I might teach for Wurzweiler, and I had my master's level students, and we were talking about hard things, and one of the students expressed, an older woman, and she expressed, you know, this is bringing up a lot of memory. She said, my body is on fire. She said, my fingers are tingling. She said, my body has begun to shake. I'm kind of having a tunnel vision, and my head is hurting, and I'm feeling pressure. And, you know, just from a memory is enough to spark some of it. To me, that's a little bit of a trauma response, but our bodies are reactive to this level of anxiety. So somatic experiencing, rumination, excessive worry. Those are the main ones we experience with anxiety. It can very much disrupt my sleep. It could disrupt my eating. It could disrupt my functioning, right? If I'm feeling that uncomfortable, do you think I'm coming to an event at 11 o'clock on a Tuesday morning? Probably not. Right? Do you think I'm going to come into a crowd where I'm like a little bit uncomfortable around other people? Probably not. Right? And there's a lot of self-talk that would have to allow me to get to a group of individuals because I feel so uncomfortable. Okay? So that's anxiety. So in talking about the reproductive years, so officially reproductive years are from being able to have a child from puberty forward until all the way through the reproductive years, which is to menopause. Remember, the formal definition of menopause is 1 year without a period. So if you get it to 11 months and 1 week and you get your period, you're still not in menopause for another whole year of waiting to cease cycling. I want to acknowledge also, just by the way, because I think that like we would be out of touch if we didn't acknowledge, many women are on continuous birth control, and so they're not actually getting a period. But that doesn't mean that they're in menopause. I've had conversations with OBGYNs. I said, like, are we like skirting menopause? Are we overriding menopause? And they're kind of like, I don't know, maybe. But we also could, they said, like, we can go off your birth control and see, a person can go off their birth control and see if they get a period at that time. And if they resume their cycling, then no, you're still not in menopause. So just acknowledging that some of what we're talking about in terms of cycles are totally different than the way that we've talked about it 20, 30 years ago when women were still cycling monthly. A lot of that has changed NIDA, it has changed the mikvah experience because many women are not going on a monthly basis anymore unless they're attempting to conceive. So reproductive years is a really long time. And especially for women, you know, the average age of menopause, anybody know what that year is? 51. average age of the United States, in the US in general, is 51 when a woman goes into menopause. I have met women 53, 55, 56 that are still cycling regularly. I just feel so bad for them. I'm just like, can I please refer you to a doctor to give you pills to override your period? Like, that's just not okay. But that's just a bias, like totally a personal bias. So let's talking about reproductive years. I'm gonna narrow down the margin a little bit to talk about where anxiety shows up during the reproductive years the most. So remember, we're talking about our greatest vulnerability is when we have variation in hormone levels. I want to address preconception. So I'm thinking about getting pregnant, maybe I'm on birth control, maybe I'm considering pregnancy within the next year or two, 6 months, whatever, then I am managing birth control. I think we just have to acknowledge, again, from an anxiety perspective, if you're involved in young women who are dealing with birth control, they are expressing to you the frustrations of trying to manage their cycles. So they're having difficult times very often with breakthrough bleeding. For those that are cycling regularly, they're also struggling often with the frustrations of NIDA. And as much as I know it's beautiful and everybody talks about how meaningful it is and how important it is, I think it would be disrespectful to those of us who are doing this mitzvah to not acknowledge that sometimes it's also very stressful. And in this case, I'm going to call it stress that can produce anxiety. So you have somebody who, is regularly cycling, and she has this underpinning of anxiety. She has this kind of, I would say almost like a foundation. Her natural baseline is anxious, and then you add on this added level of significant responsibility of tracking cycles and counting and checking and going to rabbis, and it can feel very, very overwhelming and can produce a spike in anxiety. So the cycles are hormonal disruption, right? The cycles, we are changing our hormones throughout those weeks, and we are also potentially layering on another stressor, and that can produce anxiety. So our Rabbanim are really skilled in being able to pick up, is this anxiety or is this like somebody trying to just do the mitzvah properly? And many of the Rabbanim are much better at identifying, wait a minute, am I working with somebody who is really, really anxious and I need to work on the answer that I offer her actually reflects the level of anxiety that she's holding. So when we're talking early reproductive years especially, that fluctuation of change can be a space where anxiety going to spike. Does that make sense? Okay, now, let's move into attempt at pregnancy. How many of us can relate to some of the anxieties of wanting to conceive, attempting to conceive? What are some of the thoughts we're thinking about? What are the things what am I ruminating on? If I have an anxious mind, what am I ruminating on when attempting to get pregnant? Timing. Can I plan a vacation? Will there be a privacy? Do I need to go to the doctor? Why isn't it working? Right? Why isn't it working now? Anything else I'm worried about?
Gender.
Say it again? Gender. Ooh, interesting. Very good. So will it be the right gender for what I need or want to complete my family or to start my family? Good. What about names? Do we have any anxiety about names? Just a little bit? Okay, fine. So what else? Finances. Excellent. So I want to conceive, but the cost and the expectation of what this change is going to be in my life is going to be significant. Excellent. Anything else that you're thinking of in the preconception or attempting to conceive years? Or hopefully not years, but hopefully just months. Loss. Excellent. So what if it doesn't work, right? First of all, fertility. What if it doesn't work? Many people, I think, go into, it's really interesting. I had a woman who said to me yesterday, she said, I do not understand these women, and I'm jealous of these women and also angry at them when they assume that pregnancy means baby. And you know who she was talking about? Her own daughter. She said, my daughter tells me, so Ma, when I have the baby and the baby's going to be born in September, October, November, you were going to book a ticket. Did you book a ticket to Eretz Yisrael already? Because you're going to come and you're going to help me, when I have the baby. She's like, what do you mean when you have the baby? How do you know you're going to have the baby? This is a woman who had many, many losses. Right? How do you know you're going to have the baby? So I questioned her. I said, did you book the ticket to Israel? She looks at me, she goes, no. And she told her daughter she booked the ticket. That's anxiety, right? That's an awareness of significant distress relating to pregnancy and pregnancy loss. Yes?
Also, when you're trying to have a baby and people around you are asking, you're married a million years, what's going on?
Absolutely. Absolutely. So a lot of I think we promote anxiety that way, right? That conversation around oh, how's it going, right? My daughter has been married since December. She says, Ma, you wouldn't be able to believe, everybody, everywhere I walk in, they're looking at my belly. She's like, what chutzpah? She's like, it's so uncomfortable. And she's skinny. And then she like put on weight because she's happy, and she got married and she put on weight. And she's like, Ma, I look pregnant. I'm like, okay. She's like, I'm gonna have to lose weight because then everybody's gonna think I'm pregnant. Like, that's anxiety promoting, right? That's something that, especially if you have that foundation baseline anxiety, it comes up, right? Absolutely. The expectation of are you not? And then what happens if it's not so easy? What happens if we are dealing with the difficulty of pregnancy? It might not even have reached the layer of a diagnosis of infertility. But I'm aware that, wait a minute, remember on Instagram, everybody got pregnant right away? They planned their baby, their teacher, they're gonna plan their baby, they're gonna get pregnant in June, they're gonna give birth in May, and they're gonna be off the whole summer to take care of the baby. That kind of planning, right? That kind of planning, and most people it doesn't work that way, but for some it does. For some it does. So what if for me, my story doesn't line up with that perfect calculation? Okay, it can promote an anxious response, absolutely. I think it's also very interesting, especially when we're working within a culture that's very deeply intergenerational. So there's a lot of information, I think, that is shared between the generations that maybe if we weren't as connected or as living together might not be shared up or down the relational experience. So for example, a young married girl might not share with her mother exactly when she got her period, when she got pregnant, what day, what time, right? But because perhaps we live in this many people live in a very deep interconnected culture and community and possibly even a house, then the likelihood of some of that being shared is a little bit higher, and then there also can be added pressure to that. So just being mindful of what are the nuances of our individual lifestyles and how might that also increase the threat or the presentation of anxiety. So now we have this, we're so excited, we're pregnant, and now where does the anxiety begin to show up? Will it last, right? Will we be able to sustain this pregnancy? And even if we have no history of loss, we're still not stupid, right? There's still we know that baby does not always equal pregnancy. And so someone who has a threat of anxiety or there's a risk factor for anxiety, the possibility of anxiety presenting in pregnancy is higher. Some of the other risk factors for presentation of anxiety in pregnancy. Anybody know some of the other risk factors? What would put you at higher risk for anxiety? Say it again?
Not feeling good.
Not feeling good, so being very sick in pregnancy, okay? If you're staining, excellent, which is actually really, really common. Okay, so staining in the beginning of pregnancy is going to push up your anxiety. History of pregnancy loss, anxiety.
Fear of doctors.
Fear of doctors, excellent. If there's a phobia, concern, or health anxiety, absolutely.
Feeling fine.
Say it again.
Feeling fine.
Feeling fine. How do I know that everything's okay? Excellent, absolutely. Broader risk factors, financial distress, marital disharmony, like if there's a problem in my relationship, it doesn't make it better when I get pregnant. Right? I have a friend whose family had 10 children, and she said her father was abusive, and her father and mother kept thinking that they would just have another baby and it would make it better. Obviously, there's no evidence that that works. It's really actually the opposite. So they would continue to have children with the hope that this would fix their marriage. Eventually, they got divorced. Now she's a single parent with 10 children. Right? So just thinking about the marital difficulty does not get better, and it still exists, and it actually puts them at a higher risk factor. Difficulty in financials, difficulty with housing, all of those are considered risk factors. And by the way, infertility is also a risk factor. So if somebody struggled to get pregnant, even if this pregnancy was not a fertility pregnancy, they will also be at higher risk for anxiety in pregnancy. The symptoms are the same. Okay, the anxiety symptoms are the same. They're meaning pregnant or not pregnant, but more often anxiety in pregnancy can relate to the baby or the mother's health. Those tend to be the kind of the sticky points where women begin to experience anxiety is the baby well, healthy, safe, okay? Am I well and healthy and safe and okay? So that's the sticking points for anxiety. So moving into postpartum, I want to just move us into the postpartum experience. They are connected. So one of the number one risk factors for postpartum depression and anxiety is pregnancy, depression, and anxiety. So if you have depression and anxiety in pregnancy, you are at significantly higher risk of experiencing a postpartum. It's not like, well, now I gave birth, the baby's here, I'm fine, everything's fine, I'm healthy, baby's healthy, we have nothing to worry about. No, the worry just moves. Okay, it just transitions over to another space. So recognizing that postpartum depression and anxiety occurs pretty much an average of 1 in 5 to 7 women will experience a perinatal mood disorder. So we're talking about a large population of people who are struggling. Do you all think that you've met that many people who have shared with you their anxiety in pregnancy? No. Okay? So most of us kind of hold it quietly or suffer in silence. And this kind of conversation, I hope, will help remind us that that's not really the best idea. I'm going to talk a little bit about some of the ways and strategies for us to manage our anxiety in any of life circumstances, but recognizing that the hormonal disruption of postpartum, of giving birth, the drop in certain hormones that we have, the increase in hormones for lactation, okay, so the drop in estrogen, the drops in oxytocin, the increase in prolactin so that we can breastfeed, that hormonal disruption is one of the most significant ones we go through as a reproductive age woman. And that's probably our number one space of vulnerability for a mood disorder and for mood disruption. I'm hesitating on talking about it exclusively as a disorder because I think most women will say things like, it's not that bad. I mean, it's bad, but it's not that bad, with an imagination of what that bad really is. And I want to acknowledge that I haven't really I haven't seen anywhere in any of our mitzvot, in any of our Torah, I have not seen anywhere, I've never found a mitzvah for suffering. It's not there. 613, not one of them says there is a mitzvah to suffer. And yet, very often, we seem to tolerate a lot of difficulty and a lot of suffering, and I want us to consider challenging that experience in our own lives and helping others challenge it in theirs. So in terms of postpartum, again, it tends to be about the baby. The things we're going to hear is significant worry about my health or the health of the baby, sometimes the health of a family member as well. It'll be things like, how do I know if I'm feeding the baby enough? How do I know if they're getting enough? How do I know if they're gaining weight? How do I know if they're one of the most common ones that I hear that's immediately upon hearing it, I consider anxiety, is they're not making eye contact, they're 3 weeks old. They're not making eye contact, maybe they have autism. It's one of the most significant, red flags for me as a therapist is to say, okay, something is of heightened identity right now. We're not talking about a 2-year-old that doesn't make eye contact. We're talking about a 2-week-old that isn't making eye contact. They barely open their eyes, let alone make eye contact, okay? So that would be a red flag for me. Thinking about, I can't let anybody else hold my baby. I'm the only one that should be holding my baby. Anybody met anybody like that? Mm-hmm. Anybody think about, I could only let my mother hold the baby, but no one else. Even my husband, I'm sure he's not doing a good enough job. I remember my husband held the baby for the first time, our firstborn. He held her like a football. He has very long arms. He's holding her down here. I'm like, honey, pull it up a little bit. So he would hold her like this. It took him a little bit of time to figure out how to hold the baby properly, okay? But he was a little nervous about it, but he got over that pretty quickly. So how do I tolerate other people helping me, holding the baby, interacting with the baby, and potentially even being around me? COVID created a lot of complexity in that. So because it felt like being a good mom meant I was going to protect my baby at all costs. Nobody could touch, nobody could look, nobody could be near me. You have to go 25 feet away, not just 6 feet away. That kind of experience for women who had anxiety just pushed their anxiety to really high levels, really, really significantly high levels. So thinking about and before I come back to kind of what do we do with this experience and what do we know about anxiety, I want to again acknowledge what we also are hearing, and there's very little research on menopause, very little. But as we finish our reproductive years, what we really know is that the likelihood is that level of hormonal change also is prompting anxiety and depression in women. And I will hear more than one woman say to me, I never had anxiety before. I've just never dealt with that. I didn't have depression. And all of a sudden it's coming out of nowhere as my period is declining or as I'm going through hormonal changes. So I feel like we just have to drop that pin there. For those of you that it's many years off, just remember some ladies spoke about it one time in a pretty backyard. But for those of you that it might be something you're kind of approaching in years, just keep that in mind, that if you begin to feel different than you think you should, life is okay, why am I increasing in worry and increasing in depression and anxiety? Start asking questions to people who could potentially help you. I want to make one like PSA, one public service announcement about medication and pregnancy before I actually discuss a treatment and like a management approach. So the most important thing I want you to know is that most medication is safe compared to exposure to illness. So that means that if someone is unwell, struggling with anxiety, struggling with depression, and a medical doctor says, I really think you would benefit from medication, and medication is effective, we really encourage them to stay on that medication in pregnancy. We do not agree with we, and I mean Postpartum Support International, American College of Obstetrics and Gynecology, do not agree with pulling a woman off of medication before she becomes pregnant. There is a lot of myth around that, and that is the way it was done many, many years ago. But based on the tremendous amount of data we do have about safety and medications, we really want to encourage women to be well. To be well while they're pregnant, to be well while they're postpartum. So on medication before, consult with your doctors or a specialist, but most likely stay on that medication with very, very few exceptions. So we want the most important kind of contributing factor to wellness in pregnancy and postpartum is whatever was working before. So stay healthy, take care of your babies, take care of your pregnancy, take care of your babies, and being able to take care of yourself and your family. So what is anxiety? We've talked a bit about what anxiety sounds like. I think that anything starting with the sentence, what if, should kind of, and how often am I asking what if, is a great indicator, a red flag for me, okay? What if something happens to my baby? What if I hear the train? What if that train crashes? What if it blocks my way home? What if I can't get home in time for my flight? Like things like that. What if there's something wrong with my baby? What if I'm missing the sign? What if the baby doesn't make eye contact with me? What if I have no idea how much that baby is taking in? What if the baby's not thriving? What if the baby doesn't like my milk? What if the baby spits up more than they took in? Do you hear the rumination? When I ask a woman who is in my practice in particular, I will specifically say to them, so how many times a night do you get up to check on the baby? With the assumption that they're getting up at night to check on the baby. And I'll have women who'll say about like every hour or two. How much sleep is she getting if she's getting up every hour or two to check on the baby? Okay, so when I'm hearing that level of involvement in worry, it moves over to that level of concern. Okay, so when we're thinking about what if, more than I'm thinking about living and enjoying and pleasure and just kind of like normal life things, that's when it moves into an area of concern. The what if is where we want to become more and more concerned. Now, here's the thing about anxiety. There's a part of this that is epigenetic, okay? There's a part of this that is in our DNA. If we didn't feel nervous, worried, on edge, looking around to see where there's danger, we would never have fled from the pogroms. I'm speaking as an Eastern European Jew, okay? We would never have fled from like, oh, we got to get out, the Nazis are coming, right? There's a component of our genetics that tells us it's time to go. There's also a component of our genetics that warns us that there's danger, okay? So, and we have it in our systems. This is, even if you are not from families of the Holocaust, you are at some point in time, we're on the run. And so genetically, we actually are very much aware internally of the risk and threats that are around us. So there's a part of this that is actually genetically oriented. Does that make sense? Right? So even if I myself did not experience that threat, even if my grandparents did not experience that threat, my historical DNA did. And so I am a little bit more connected to anxiety than perhaps the general population. So being aware of that. There is many components of anxiety that are functional. Anxiety makes me go to sleep so I can get up on time, so I can come here on time, so I can speak on time. Right? Anxiety will make me worry about feeding my children nutritious meals. I'm going to make sure that my anxiety will prompt me to cook or find out how do I cook a nutritious meal for my family. Right? There's a component of anxiety that's very helpful. Anxiety is a motivator. Right? If I don't do this, then this will happen. It makes sense to me to then use my anxiety as a motivator. But when I'm highly anxious, any person is highly anxious, there's also the risk of shutdown, and that's where it becomes dysfunctional. So the shutdown part is my anxiety is keeping me up all night. I could barely get out of bed in the morning. I'm ruminating for many, many, many hours. I can't keep my head focused or my focus attending to any specific task. I'm very overwhelmed with the things that I don't know that other people are particularly overwhelmed with. Oh, and by the way, my sisters or my mother are worried about me, or my husband is worried about me. And that is where anxiety, again, reaches that level of maybe not as functional as I'd like it to be. So can I manage it? Okay, that becomes my question. Can I manage my anxiety? Is it manageable? And for many people it is. And we have learned perhaps along the way, either by survivorship or by education, we've learned how to manage our anxiety. And we also need to be aware of at some point, does this become dysfunctional? So I can be like low baseline, anxious kind of brain, maybe that worry-wart nature, and then something happens that pushes my anxiety to a point that it becomes no longer manageable. And whatever skills or techniques or interventions I've used before that have worked for me are no longer available, or I just can't seem to get them going. I can't seem to initiate the things that I really find particularly helpful. So how do I know? Okay, how do I know? And what are some of the things I can do to help myself, and what would be those strategies? So how do I know? Somebody's telling me. Typically, somebody's telling me, I'm worried about you. Like you're on edge, right? You're short-tempered. The way that anxiety very often will look in women, especially postpartum women, is irritability. By the way, men too. This is not just women. Men too. Very irritable, very on edge. Many women will describe postpartum rage. Anybody hear that terminology before? That they were angry. The thing that would not typically make them angry before is making them angry now, right? Like the thing, I saw a very funny like meme or video or something where someone goes, I don't have to track my cycle because as soon as I start getting annoyed at my husband's breathing, I know my period's coming, right? Like we know the things that would not normally irritate us begin to irritate us or are really grating on our nerves. It would be a way to describe it, or are making us upset, irritable, or anxious. That might be a sign to me that my level of functioning potentially is declining if it doesn't like revert back pretty quickly. So the reality is we can't live worry-free. It's not possible for us to be like, I just want to get rid of it. I just want to not be anxious. I just want to be happy, right? That's always on the intake. I just want to be happy. I'm like, oh man, this is going to be a long educational process, okay? We all will live with anxiety and worry. It's by nature and it's functional. The question is, what can I do to bring it down to that baseline that is functional? Okay? What are some of the things that you've done that you know is helpful to you with your anxiety? What works? Exercise, absolutely. What else?
Self-care.
Self-care, what does that mean? I know somebody said self-care, but go ahead, I'll come back to you.
Like, I was gonna say something else.
Go ahead, yeah.
Okay, so like talking it out with my husband definitely helps me.
Excellent, talking it out with my husband. Good, somebody said self-care, what does that look like?
Massage.
Massage. Okay, good. I'll take a massage anytime. By the way, somebody who's highly anxious, the massage could be helpful for a period of time, and they might notice by the time they get back to their house, they're not so calm anymore. So that would also warn you that we might need a little bit of an extra intervention. Other self-care routines?
Anything that makes you feel good. Everybody's individual.
Yeah, what are some of yours?
Exercise, manicure, pedicure, having lunch with a friend, learning. I think faith is big for anxiety.
Beautiful.
There's a lot of that.
Yep, absolutely. So faith-based or spiritual-based intervention, engagement with friends is a big one. And the reason, if you have good friends, you have to have good friends. You can't be the friends that are like the society friends. They have to be people that you can like be vulnerable and let your guard down friends. The one who's like, I'm having a miserable time right now and I hate my husband and my kids. And that friend who's like, okay, when was the last time you took a shower, took care of yourself, and ate something nutritious? Let's go out and hang out together, right? That we need those friends in our lives. So if I have to feel like I'm on show with those friends, might not be as helpful form of self-care. But again, I think we were noticing for some, it's like physical. It feels like I think actually historically it's been sold as very physical, like a massage, a manicure, pedicure. I've learned over time that that's not actually the most important thing that women find helpful. It's good, and I would always claim it as self-care. Honey, I need to go get my self-care. It's Friday afternoon, right? Please do the dishes. So I definitely will find self-care in those routines, but there's other things that are more valuable. For me, it's friends. For me, it's exercise. I know that when I become more isolated, like I don't have time for the friends, and I haven't spoken to my buddies in a while, my girlfriends in a couple of weeks or days, and it's like, I'm not okay. And so I reorient to those relationships which are strengthening and grounding. Excellent. All right, let's go one more. Let's go from the beginning. I'm going to give you 4 sort of S's. You ready? Number 1 is sleep. Our brain declines. Our cognitive capacity declines without sleep. Remember those postpartum women, right? We expect them to just do that. It's horrible. And yet, we know that sleep is incredibly protective of our mental health. Sleep, number 1 of my priorities. If I can help a woman figure out a way to get more sleep, it is not a question, we will see her anxiety come down. So by the way, one of the questions we'll ask is not, are you sleeping? I would say, if I was to take care of your baby, do your laundry and your carpals, would you be able to sleep? Right? Because my mother would say things like, well, when the baby's sleeping, you should sleep. I'm like, yeah, who's doing the carpal and the laundry? Right? Like somebody also has to do those other responsibilities. So sleep is protective. You might notice a decline in anxiety just from helping a woman figure out a way to get sleep, you included. Okay, many of us are up way too late at night. Sometimes it's the only time we have quiet. And so I've heard it referred to as like revenge hours. Like we get to like take revenge on all of those who need us all day long, but really we're punishing ourselves, right? Where the next day we are exhausted and like can't function, but boy, did I enjoy that hour scrolling on Instagram, okay? Or doing absolutely nothing, and nobody was calling my name. So sleep is protective. So if I can help somebody find some extra hours of sleep, if I can get extra hours of sleep, do I notice that my anxiety has come down? And so that's really indicative of one of the number 1 influencers of anxiety. Number 2, okay, sleep, support. You mentioned it, friends, connection. Sometimes therapy can be very supportive, family and friends, okay? Sometimes, by the way, our husbands might say to us, it's too much for me. Like, I want to support you, but I need you to also get support from other people. Sometimes it's overloaded on our spouses, and they're beginning to drown in our anxiety as well. So being mindful of that concern, how much can my family and friend, spouse tolerate? And do I need other kinds of support? Support groups, supportive connection with relationships, friends, and potentially a therapist as well. So number 1, sleep. Number 2, support. Number 3, strategies. We need to have techniques. For some, it'll be learning things like CBT, for cognitive behavioral therapy, learning techniques to manage our anxiety. Things that are holistic, exercise, nutrition, spending time alone, spending time with others, absorbing nature, mindfulness. Those are all documented strategies that are helpful in reducing our anxiety. And the 4th one is a pretend S, because it starts with a P, and I'm going to call it psychiatry. Okay, so sleep, support, strategies, psychiatry. Yes, I know how to spell it, but sometimes we do need to reach out for medication. And I just want you to consider the reality is that medication does not prevent me from doing the first 3. Meaning, even with medication, I need to take care of myself, I need to have support, I need to have sleep, and I also need to have strategies to manage the anxiety. But what I have seen is medication can take the edge off of that feeling of overwhelm, or the edge off that feeling of I can't get to sleep, or the edge off of I hate everyone and everything. Okay, that edge can kind of tone down with some medication. Always medication, safest medication is always going to be ones that are non-addictive. So we're typically looking at an SSRI. The common names would be Prozac, Zoloft, the Lexapro. Those would be the primary kind of choices that most psychiatrists would choose at first. So in review, anxiety is epigenetic. It's part of who we are. Anxiety can be functional. It's part of what makes us motivated to do things to make change. Anxiety also can be dysfunctional and very, very problematic. And also anxiety can get better. With the right support, with the right help, with turning to the experts to say, I don't know that I'm as okay as I want to be. I want to feel more joy. I want to be able to experience an afternoon like this and just relax and enjoy it. Even if I'm worried when I go home about like, what am I making for dinner? Take some leftovers. No, just kidding. Right? So like if I have to know like what are the things that I need to make my life a little bit better, but if most of the time I'm able to manage these emotions internally, it will get better, and it absolutely can get better for everybody. So thank you so much for being a part of this conversation, for being willing to enjoy this magnificent afternoon, morning with us. I'm here to answer any questions if you'd like before we transition over to lunch. I think because of timing, probably want to just allow people to go inside and get lunch, but I'll stay here to answer any questions specifically. Thank you again for inviting me. Sure. Okay, Mrs. Haber has a question. Yeah.
Birth control, everybody's on birth control, whether it's it's really affecting them. And I think that's something that has to be like this recognized.
So, Mrs. Haber, I did bring it up in the beginning. Mrs. Haber just wants me to say one comment about birth control. Right, you heard it. I just want to make one comment about birth control. If you notice significant mood changes around your new initiation of a new kind of birth control, don't ignore it. Don't assume that it's like, oh yeah, that's normal. Like if you're seeing a change, you're very, very anxious, you're feeling moods of, depression, ask more questions about like, why am I feeling this way? Is this just, transitional? Is this going to change? Things like that. Okay, go enjoy your life.
Welcome, everybody. Anyone that knows me knows it's not my type to be up here. But for family, I would do anything. And everyone involved in SBH Fertility is like family to me. My amazing partners, our amazing, humongous group of volunteers, and most especially, those of you that reach out to us and include us in your journey. My years of struggling with fertility are long behind me. But the aloneness that surrounded me in those years is something I will never forget. I specifically remember the people I reached out to, but more importantly, I remember the people that remembered me and remembered to follow up with me and see how I was doing. What sets SBH Fertility apart? It is written in the Gemara that he who saves one life, it is as if he has saved the entire world. There are no cookie-cutter approaches with us. Each call that comes in becomes its own dance. With the help of Hashem, we listen and then we work on the best treatment plan based on the client's needs. Our case managers are available 24/7 to help guide each client to the right care. We work hand in hand with many doctors and ensure the right fit for each person. We then partner with our clients' doctors to ensure quicker appointments and top medical care and follow-up. We personally work with our clients' rabbis, and if you don't have a rabbi, we'll help you find one. And we work with all the other fertility organizations as well. What works for one woman may not work for another. Every case by us becomes its own world. We are constantly learning and growing along with you, along with our clients. And we join them in their journey, step by step, day by day. Whether it's a young married woman wondering if it's time to see a fertility doctor, or a couple looking to grow their family, maybe a couple that learned they need to do IVF for genetic reasons, or a woman struggling with a loss, an early loss, a late loss, multiple losses. Sometimes it's a new mother feeling anxious or depressed to the point that she's not functioning properly. Other times it's a woman struggling to accept her situation. Not every situation has a medical solution. Sometimes what's needed is time and acceptance. Whatever you need, we do our best to partner with you on your journey, with the goal of sometimes being a baby, but always an emotionally healthy person. Whatever the situation, what sets us apart is our commitment to you specifically. Financially, we have taken on assisting with payment for costly fertility treatments. Holistically, our support groups are running constantly throughout the year. We have over 100 peers ready and willing to be matched up with someone whose journey is similar to theirs. We offer nurses to help with advice and shots, yoga classes, and honestly, anything you could think of, we work to make it happen. We also help with days like today, where we seek to further educate ourselves. Throughout the year, we speak on many fertility topics. I don't think I need to introduce Rachel, who runs a lot of our fertility Insta Lives, and I feel like she's famous, so you know how unbelievable she is and how well she runs them, and she will be our host today. And how fortunate are we to be here today in this magnificent house. Rochelle, there you are. When we reached out to you, you gave us an enthusiastic yes, and we cannot thank you enough for offering us your home and your heart. Come up so we could thank you personally. Ready to start? Okay. A few years ago, when this whole division was still in its early stage, I sat in a meeting and told Gladys Hazen that in my next lifetime, I'm coming back as a radio DJ host, and I want my own talk show. I have no clue what prompted me to say something so ridiculous out loud. It's the type of comment I need to learn to keep in my head. But fast forward a few months later, and I was put to work on either a panel or an Instagram Live. I don't remember which came first. But I do remember Mrs. Molly Haber calling me before the first time that I was speaking, just to check in and make sure that I'd convey the right message to the audience. When I expressed that I was nervous, I know that's shocking to hear, she told me that right before I speak, I should just ask Hashem to put the right words in my mouth, and I'll do fine. All these years later, I've probably prepped about 25 speakers and spoken on numerous panels and lives, and I still say those same words under my breath each time. Please, Hashem, put the right words in my mouth. Stop my heart from racing so quickly from nerves, and please allow me the strength to share my journey, represent SBH Fertility with integrity and respect, and sneak in my own personal touch and message that might resonate with somebody sitting here today. So far, my little prayer hasn't failed me, but I realized God's simple trick. He surrounds me with brave speakers who are filled with a wealth of experience, knowledge, and perspective. Infertility can be a very isolating journey fraught with emotional highs and lows that are very difficult to convey to an audience. However, together, the panelists and I tackle this challenge, and as a result, a powerful sense of camaraderie emerges between us. We draw strength from one another, and their resilience, faith, and perseverance through hardship are what inspire me to speak the right words. No matter how many journeys I've heard, they never get old. The new emotions and insight always manage to deepen my understanding and empathy for this beautiful little community that we've created over the last few years. Barbara Cohen told me the other night, we are the worst club with the best members, and I told her I was going to steal that line. Ironically, I'm very grateful to be a part of this crew, and I have you all to connect with, and I'm very grateful for that. So thank you all today for joining us to hear our speakers advocate for awareness, shed stigma, and share their knowledge on everything from infertility, loss, and perinatal mood and anxiety disorder. Some of them have spoken and been vocal in the past, and some are sharing their journeys for the first time with friends and family sitting here today. So kindly silence your phones, and let's start with our first speaker, Mrs. Jamie Sudri.
Thank you so much, Rachel. First of all, I want to thank you for all the help that you gave me the last few days preparing what I want to share today. Thank you to Mr. and Mrs. Franco for opening up your house to such a beautiful event. I hope that we'll all gain from each other like what's intended. I'll start with a brief little overview of my experience. Baruch Hashem, when we got married, I soon after became pregnant, pretty much right away. And when I was still nursing that child, became pregnant with my next child. When I was still nursing that one, became pregnant with the next. When I was nursing that one, I became pregnant with the next and expected it to be the same easy ride like I had had before. However, this time I suddenly started staining. And shortly after, was confirmed to have experienced my first miscarriage, completely taken by surprise. After that, got pregnant again, miscarried again, and then miscarried again. And at this point, my mind started to just go crazy on me. Was it something I was eating? Was I exercising the wrong way? Was it because I moved and I changed my mazal? Of course, now I know that all that wasn't true, but the thoughts were just racing through my head. At that point, our doctor had agreed that it was time to see a specialist. And the specialist did a whole gamut of tests on us from A to Z, and he came back to us saying that everything was normal. He didn't see anything wrong. And that response gave me really mixed feelings. On the one hand, that was great. Everything was normal and everything was good. And on the other hand, then what do we do? And why is this happening? There was no explanation and nothing really to do. He suggested that I take a baby aspirin and a progesterone, and there's no guarantees, and it may not help, it may not, I don't know. But you can try. And so that's what I did, and ended up having another 2 miscarriages. So at this point, it was 5 in a row. And then I became pregnant again. And at this point, I was completely paranoid. I was constantly checking myself if I was bleeding. Every single cramp was like, oh, is this it? And Baruch Hashem ended up having a delicious, healthy child. After him, I had another 3 children with a bunch of miscarriages in between. In all, I had about 10 painful and difficult miscarriages. A lot of the details of my experiences are very blurred and foggy in my memory at this point, but there are particular moments that stand out in my mind. Ones that in hindsight I realized have remained with me because they've had such a deep and lasting impact on who I am and how I live my life. And it's those moments that I'd like to share with you today. The first was about a week before my first miscarriage, when my sister actually experienced her own first miscarriage. And she turned to me for support. At that point I was expecting, but she didn't know it, I was very early. And thinking that I was being such a supportive sister, and of course I was sharing with her, and I felt so bad. But I said to her, it's very common. I hear a lot of people go through this, it's not so crazy. Little did I know a few days later that I'd be the one devastated and hysterical, thinking to myself, how could I have said what I said? The words that I said to her were the last words in the world that I had wanted to hear. It's true that it's common and normal, and a lot of people go through it, but that did not make my pain any easier to bear. And so the first thing that I learned is that we really can never understand or calculate how another person should be experiencing any difficulty that they go through. Yes, a lot of people go through this and it's normal, but that did not make it any easier to bear. Second was also when I was having my first miscarriage, when it was really at its most intense point, was the night of my son's 3rd birthday party, and everyone was coming to my house, and everyone was coming over, and no one knew yet what I was going through, and I wasn't going to share it with them and dampen the whole night. So I just remember sitting there on the floor in pain, emotionally, physically. I could hardly move, my face grimacing, trying to smile, a fake smile, really not being myself. And I just wanted to scream out you have no idea what I'm going through right now. And even the next few days, as I was doing my errands and running around and I felt like I just wanted to have a label that said please understand I'm not exactly myself. I'm having a miscarriage, and it's painful, and I'm uncomfortable, and I'm really sad. And it taught me that really we can never judge anyone, because we never know who's going through what they're going through and why someone may not be acting exactly themselves. The third moment that stands out in my mind is when we got to that point where it was time to reach out to a specialist. And I had spoken to Debbie Rami, and I expressed to her how challenging and unexpected and confusing all this had been, and that I also had feelings of guilt. I had very close friends that had not yet been blessed with children that were also experiencing miscarriages, and I felt like I have kids, I don't have a right to feel so sad, maybe it's not. And I expressed that I was feeling that way, and her words were so comforting, and they still echo in my mind. She said, Jamie, every single loss of life is a real and complete loss. It's not just a miscarriage. For any couple who goes through this, it's a loss of a whole life, it's a loss of a whole dream, and therefore we'll do whatever we can to help anyone, whether it's their first, their second, their 5th, or their 10th. Each one is important to them, and so each one is important to us. And with those profound and soothing words, she referred us to our specialist. The fourth, Mrs. Haber, She is like a second mother to me in every aspect of life, but especially along this journey. Her and the Rabbi, Alav Hashalom, have guided us every single step in the way. In general, her texts of, how are you and how are you feeling, just seeing her name pop up on my phone and knowing that she was thinking about me was like a warm blanket on a cold night, like just the best feeling ever. I remember coming home from one of the DNCs, and before I even got home, right by my door was this care package with a delicious dessert and slippers and lotion, and especially a beautiful message. And there was one during one of the miscarriages when I expressed to her, where I expressed to her that I was feeling so sad, but not just sad about what I was going through, but I felt sad that I was feeling sad. I said, like, I really have emunah in Hashem. I really believe that everything that happened was for the best, so I feel like I shouldn't be sad. Like, why am I still feeling sad? You know, she has a way of delivering such a strong message in a few words for anyone who knows her. I couldn't wait for her response, and finally I opened it up, my text, and her response was, you'd better be sad. And those words didn't just make me feel like it was okay. It was expected. Of course you should be sad. It made me realize that feeling sad and experiencing pain and having emunah do not contradict each other. This is a normal human experience that we have. And yet, in my heart, do I know that Hashem is doing so? Do I know that this is for my best, that this child had been born would not have been the best thing for me? Knowing that it was okay was such a good feeling. And I remember I began to cry, the most therapeutic and relieving cry ever. Lastly, I'd like to share, this was a feeling that I just felt a few days ago. As I was looking at that first child that was born after those first 5 miscarriages, I was looking at him, and I just started to have flashbacks, maybe because I was preparing for today's event, and I was just thinking about all the fear, the confusion, the pain, the doctor appointments, the hopes, the disappointments, the prayers and prayers and prayers and more prayers. His name is Yehuda, and I looked at him and I said, Yehuda, you know the pasuk about your name? He knows this pasuk about his name. It's Hapa'am odeh et Hashem. This time I will thank Hashem. So I said to him, you know that pasuk? One day, Yehuda, you're really going to understand what your name is really about. One day, you'll know how special you really are and how a whole lot of tefillot brought you here. Before his pregnancy, I took my easy pregnancies completely for granted. Had another appointment, another drive to the city, another parking, just to go in for the doctor to look at it and say, everything is good, come back next month. It was like a nuisance. But after all that we had endured, every single appointment, every sonogram, every sound of a heartbeat, every sleepless night, every endless feeling tantrum, every crazy mess from this child and every one before and after him, every one of them are all saturated with overwhelming feelings of gratitude to Hashem that are just indescribable. And so, we may have never appreciated those precious gifts. So we are forever, forever, forever grateful to Hashem that through our losses, we were given the opportunity to gain the gift of gratitude. Thank you so much for hearing me today and sharing in my journey.
Jamie, I just want to touch for a second on something that you said about holding back judgment, right? When someone's not acting themselves, it's a really big challenge that we have to take upon ourselves because we are seeing firsthand when women experience something that's hard, we are forced to go about our daily lives, our daily tasks. We're wives, we're mothers, and inside things hurt. And it just makes it easier when people hold back judgment and treat you with empathy and kindness, even and especially when they don't know what you're going through. It's a challenge we all have to take upon ourselves. But it seems like so many of your miscarriages happened while you were simultaneously raising a family of small children. Could you tell us a little bit about how the miscarriages affected both you and them during that time?
Sure, thank you. So each one was really a different experience. Some of them were DNCs and I had to go to the hospital for a procedure. Some of them passed on their own. And so a lot of this was, while I'm raising my kids and I'm disappearing. The more recent ones were now as they're getting bigger and they're starting to catch on that things were happening, and it wasn't the type of thing that I wanted to explain to them that I was going through it. Particularly the last miscarriage that I had, my daughter she was about a year old. And again, I was nursing. And I really, really enjoy nursing my babies. And I did not want to stop. But I found that I was pregnant, and it becomes very difficult and draining for me to continue. And I said to myself, okay, once I hear a heartbeat, then I'll stop. And I went to the doctor, heard a heartbeat, and those are when it's a lot more difficult to go to the next appointment, when I did not, there was no longer a heartbeat. And at that point, I already stopped nursing my baby, and that was like a really difficult experience.
Thank you for sharing. And please, our next speaker, Flora Salman. We'd love to hear from you.
Hi, everybody. I would like to thank Rochelle and Elliot for opening up their home and hosting such a beautiful day on behalf of such an important division of SBH. You're going to have to bear with me. I don't speak well. Okay. I should preface by saying that before having kids, all complications relating to pregnancy never even crossed my mind. I always thought that this would never happen to me. Why would it? Sorry. At my 20-week scan with my first pregnancy, I walked in alone, excited to see my baby on the screen, and I walked out shaking. I was told that my baby had polydactyl, an extra bone in her left hand, and that it could be an indication of a life-threatening and fatal heart issue. I was also told it could be absolutely nothing and just an extra bone. We followed that up with a fetal echo, which thankfully turned out to be absolutely nothing but an extra bone in my daughter's left thumb. A simple cosmetic issue that tormented me up until the day I gave birth. The day finally came, I was induced, and almost a day later, just as the 4th of July fireworks exploded over New York City, she came out, barely breathing and unable to regulate her temperature. I held her for 30 seconds, passed her to my husband, and they ran her off to the NICU. All I thought was, what if the fetal echo was wrong? After 3 days in the NICU, they finally brought her up to my room and left me, once again, alone. Within 3 minutes, she vomited all over the bassinet. It was black. I screamed for someone to come. I had no idea what happened. I was terrified. The nurses assured me it was fine. She had swallowed a lot of meconium inside my stomach, and it was still coming out. I spent a good 6 months constantly checking her while she slept to make sure she didn't do that again. At the time, I thought my anxiety was a normal thing. Looking back, my first pregnancy and postpartum period were not normal and were a clear indication of what was to come in subsequent pregnancies. My not-so-little firecracker is turning 7 this Thursday. I still check her specifically to make sure she's breathing before I go to sleep every night. Is it anxiety? Maybe. A habit? Maybe. A trauma? For sure. Thank you. Fast forward to January 2019. We decided to expand our family, and we got a positive test on our first try. We spent the first few weeks of pregnancy going back and forth to the doctor, following up on a faint heartbeat and a slow growth curve. Every week was like waiting a year. 12 weeks came, and after a 30-minute scan and 3 different doctors and sonographers coming in to examine me, we were told that there was unfortunately no heartbeat. I went back to my doctor, and he explained our options: wait for my body to expel everything naturally, or have a D&C and get it out. I told him to put me in for his next available appointment. My plan for my kids to be closer together in age was now ruined. Luckily, I was told that since the pregnancy was 12 weeks along, that I only had to wait until my first period to try again. 2 very long months later, while on a trip with a bunch of friends, I got my first period since the loss. When I came out of the bathroom, my 2 best friends knew something was wrong, and I almost immediately, the emotions that built up after my loss poured out. It was the first time I had really spoken about it. Thankfully, I got pregnant again quickly. My anxiety was already through the roof, and to make matters worse, at my first appointment, the baby was measuring small again. The entire pregnancy, I was so stressed out that I wasn't nauseous. I would go in for checks more often than needed, just to confirm everything was okay. February 18th, 2020, after being a whole 2 weeks late, I was once again induced and gave birth to my second daughter. A month after I gave birth, the world shut down. COVID. I got 0 sleep. My baby would be up crying all night long. My 2-year-old wouldn't go to sleep until midnight and would wake up in the middle of the night once I finally got back to sleep. I heard nonstop crying from both kids for weeks. My newborn was crying all day and all night. My toddler was crying all day and all night. And you guessed it, so was I. Those who know me, and even those who don't, know I had a village with my first. I was used to having my baby passed from hand to hand. My oldest had weekly weekend sleepovers at my parents'. I got my sleep the first time around, I really did. This time, I got none. I needed my village. Imagine being 2.5 years old, the first grandchild, niece, going from everyone always playing with you, taking you places, seeing you all the time, to nothing. It's safe to say she was almost as miserable and angry as I was, and I probably wasn't making it any easier at her. I was frustrated and yelling at her all the time. I thought things would get better when I moved in with my parents for the summer, but my baby never slept, day or night. I was delirious from a lack of sleep. I had no desire to see people. I couldn't sew or design anything, something I really loved to do. I couldn't take care of myself. I tried to get through the day without completely collapsing or losing my cool on everyone. Hanging out with my friends became a task. How was I getting my kids fed, bathed, asleep, and getting myself showered and ready to go? And if I finally tried to get dressed, when I realized I had nothing in my closet that fit, I would just get in bed and stay home. I didn't want to get pregnant again until my daughter started school. I needed a serious break. And once I finally started trying, for some explained reason, month after month, I just wasn't getting pregnant. I was told by my doctor to set up an appointment for an HSG exam to check if my tubes were blocked, and that I had a high chance of getting pregnant the following month after having this exam. And if not, we would start to explore further options. The only problem was I couldn't get an appointment. Unsure of what to do next, I signed up for a secondary infertility group. With the help of Gladys and SBH Fertility, after months of trying to get an appointment, I finally got one. It was the most painful procedure of my life, but it was worth it. Luckily, I found that I was pregnant the following month. Soon the hormones started kicking in. I was so happy to finally be pregnant, but also just as nervous as the previous pregnancies. Does my baby have all the correct limbs? Does it have a heart condition? Is it measuring too small? Is it going to make it past 12 weeks? Should I bother telling anybody? Am I feeling enough movement? Should I go back to the doctor again? I was going crazy. It's all I thought about all day long. Everyone in my life was getting on my nerves. Even strangers on the street would set me off. Why couldn't I just chill out? I had to do something. I called Gladys and I said I needed help. I asked to join the Power Moms group, even though I was still pregnant, because I knew that the anxiety would get worse once I gave birth. To my surprise, I was not the only one. In fact, 2 other girls in my group were also 6 months pregnant. We each had different issues going on. Some had mom guilt, some the first-time moms had anxiety being alone with their babies, some not able to enjoy their time with their babies at all. Many of us felt like we were terrible moms and not doing enough, even though we had no time for ourselves. How did other moms make it seem so effortless? People tell me all the time, Flora, of course you know how to do A, B, and C perfectly. Your mom has got clutter. You're so talented. How do you do all these random things? They expected me to be so on top of everything, yet I always felt like I was drowning. I couldn't get my house under control. My laundry never made its way to the basement. My beds never got made. I couldn't figure out what to do first. What's for dinner? Who knows? Not me, that's for sure. Why couldn't I figure out how to get through the day like a normal person? After a while, these weekly nighttime support group meetups got really exciting. After all, who doesn't like unapologetically venting to people who actually understand what you're going through? Finally, people who can actually relate without judgment. It may seem silly, but we would support each other just for doing something as leaving the house for 15 minutes to get some fresh air. After the support group ended, SBH set us up with 2 fun nights out. Then we each began taking turns hosting a mom's night out, an excellent excuse to have our husbands deal with bath and bedtime and go do something for ourselves. Bye, I have a postpartum group meeting at 7, gotta go. It took a while before we actually told them that our group ended months prior. We got together often for dinner and craft nights. One girl hosted a candle painting night. Sorry. Another hosted a jewelry making night. I hosted a sewing class where we made our own bags, and we most recently went and took a pottery class. Our husbands now make fun of us that we're like a bunch of old ladies looking for new hobbies to keep ourselves busy with. Surprisingly, another thing that helped me relax was my work. I run a program called Fashion Camp, and about 2 months before I gave birth, I started getting more busy than usual. In the past, I would sit around and stress and plan during the pregnancy, but now I was so busy planning each and every single day full of fun and exciting projects, I had no time left in the day to overthink about my baby. I had many moms dropping their kids off, all asking, "How are you doing this? Are you okay? You're crazy, you're nuts." Little did they know, they were doing me the absolute biggest favor. I had 40 kids making the biggest mess in my house the days leading up to Passover. I was hosting every meal, and I've never been more relaxed. I felt so good and most of all productive. My mom, the real OG power mom, always tells me that the busier you are, the more you get done. And this time, I never believed her more. April 28th of last year, I gave birth to a healthy baby boy and came home with a sense of calmness. 3rd kid, I got this. I had Gladys and my Power Moms group constantly checking in on me, making sure I was all right. It felt like I had my village back. The hours between feeding and naps didn't feel so empty like they had in the past. I got myself on a schedule, I got my kids ready and off to camp, I got my baby to nap, made it to the gym or the boardwalk most mornings, made an effort to get out and meet friends for lunch during naps. I kept this up for quite some time, until this past February when, surprise, I found out I was pregnant once again. God willing, my husband and I are expecting our 4th child this October. Am I feeling the same as last pregnancy? Sometimes. It's definitely a challenge and I have my moments, only now I'm way more aware of my emotions. I have to give a shout out to my Power Mom 7 group, especially Linda Bennon, whose phone is most likely buzzing through the night. Guys, her phone is ringing off the hook nonstop. They're all constantly listening to my rants when I'm stressing out over anything, big or small, and helping me get through it. I don't always offer my opinion on such sensitive matters without someone asking first, but if you ever need someone to give you a reason why you should join one of these groups, I happen to know 8 amazing moms who would gladly join me in convincing you why you should. Thank you.
Sorry, we have some competition in the background. Hopefully it's almost over. Flora, throughout all of our conversations and the journey that you just shared with the audience, your sleep deprivation was something that you really put a lot of emphasis on. So can you tell us a little bit more about how it affected you, how you might possibly spot it in someone else who's experiencing it, and what you would do to address it in a friend?
Sure. So, first of all, this applies to literally everybody. If you have a friend, a sister, a cousin, a daughter-in-law, you notice they're not getting out much, they're very irritable, they're not themselves, they don't want to do anything, reach out, make sure they're getting sleep. It's very important. Moms and mother-in-laws, make sure their husbands know that they need to get sleep. Friends, you need to keep reaching out, making sure they get out of the house. It's so important to get out of the house. I can't tell you how many times I've sat home for weeks doing nothing, literally nothing, until I have someone to force me to go do something. But most importantly, just make sure your moms are getting sleep. because it affects everything they do throughout the day. And if they can't take care of themselves, they literally can't take care of anyone else. That's
Thank
it.
you. There's a few empty seats in the front. If anyone standing wants to come sit, now's a good time. You're not interrupting anybody. And we'll start now with our next speaker, Marlene Saada. Thank you.
Hi everyone. You could hear me? I just want to start off by thanking our hosts, Rochelle and Elia Brinko, my neighbors and friends, and SBH for having me and for everything that you do, Rachel for all your help. My journey started 11 years ago. I had just given birth to my third daughter. She was adorable, and a few hours before I was ready to take her home, the nurse came in and said, I just have to tell you that your daughter didn't pass her newborn hearing test. So I said, okay, what does that mean? And she said, it could be fluid, but follow up with an audiologist because it could potentially be a hearing loss or deafness. I didn't think much of it. I don't know why. She seemed like any other normal baby, but I did what she told me, and I followed up, and we did a hearing test, and to my surprise, she failed 13 times. So at that point, I knew, okay, this is not fluid. There's something going on here. After second and third opinions, it was clear that she had a mild to moderate hearing loss in both ears. I was heartbroken. I was sad. My baby couldn't hear me. She couldn't hear my husband. She couldn't hear her siblings. And I was worried. But with time and the right intervention and speech therapy and hearing aids, thank God for hearing aids, she started to grow and talk and comprehend and understand and really, really make a lot of progress. And we started to see the light. We were told that this hearing loss could be due to a gene that me and my husband were carrying, but we were never told that we could prevent our future children from being born with the same thing. So not having that information, we just did what we always did and tried a few years later to get pregnant naturally. And Baruch Hashem, we did. And I gave birth to my first baby boy. As you could imagine, it was very exciting. We were over the moon. And the next day, he was a day old, and we were doing all the birth preparations and all the planning, and a nurse came into the room and she said, I'm here to do a hearing test on your baby. And we said, okay. She did it in the room this time. So we were watching, me and my husband, and he failed, and then he failed again, and we watched, and he failed again. And the next day he failed a couple more times too. We looked at each other and we knew this wasn't fluid. We knew what this was, 99.9%, we knew. I was upset. I was very upset. My husband was much stronger than I was, and he had the right perspective. He's like, we did this, we did it, we got this, we could do it again. But I didn't want to do it again. I really, really, really didn't want to do it again. I was finally out of, the darkness, and now I was being pulled right back in and starting from scratch. But Hashem gives you strength, and you do what you got to do. So I picked up, and I went through the motions again. And while I was doing that, my mother, God bless her, she was doing her own research. And she called me up one day, and she said, I was talking to a couple that's in a similar situation than you are, and I actually found out that you can do IVF for future pregnancies if you want to have another baby. And I was like, Ma, no way, that's so extreme. Like, IVF is such a hard process. I'm going to do that for a hearing loss? Like, I don't even know if that's allowed. And she's like, okay, talk to your rabbi, think about it. So we did. We asked our very close family rabbi. And he asked his rabbis, and he came back and said it's totally fine. So we thought about it, and we decided, you know what, this is something we're probably going to do. So after a few years, when we were ready to try again, I always wanted a big family, so we tried again. And we started the process. We did genetic testing, and we found out that me and my husband carried a gene that gave us a 1 in 4 chance of any of our children being born with a hearing impairment. And then came the numbers and the percentages and the science and the doctors, and then I got cold feet. It didn't seem natural. It seemed very planned. I felt like I was playing God. And at one point I decided I'm not going through with this. I called up our rabbi and I said, thank you for all your help, but I think I'm just gonna pray. I'm gonna strengthen my bitachon, and I'm gonna just accept whatever Hashem sends my way. I thought, like, you know, it was so good, and I was having such a, you know, good outlook on the whole thing. And he said, I don't agree with you. You're trying to be a hero, but anything that is a struggle and anything that is unpleasant for our children, we have a responsibility to help them to the best that we can. Hashem gave you the tools. Hashem put IVF in the world for you to use. And by using it, you're not only doing what's okay and what's allowed, but you're having the right perspective on bitachon. You're actually doing a mitzvah. So he sold me, obviously, and I continued. And after the shots and the doctor appointments back and forth to the city every day, every other day, and the ultrasounds and the blood tests and the numbers and the whole thing, I actually found that it was the most humbling and awe-inspiring experience of my life. I couldn't walk out of a doctor's appointment without counting my blessings. I had 4 children at home, a lot of women there. Were waiting years and years and years just to have one baby. I had a husband at home. Many women there were freezing their eggs and didn't know when they were going to get married, let alone have children. I had fertility, Baruch Hashem. My genetic disorder wasn't a life or death situation. So I'm so grateful that I was able to see that. Another thing was just being able to watch the process from beginning to end. You know, they take a little microscopic seed, for anyone who knows who went through it, and they put it in you, and this embryo, and you watch it grow and grow. And I got front row seats to watch the miracle of life. I did. I really, it was very humbling, and it was beautiful to watch, I thought. Baruch Hashem, I had 2 successful IVF cycles and 2 healthy, beautiful baby boys. And they passed the hearing test with flying colors. I'm sure you could imagine what that felt like. I just want to say a few things for anyone who's going through something like this or going through IVF in general. A few things that really helped me. The support, number 1, the support. We have tons of people in our community who are there to help us, who are there just to answer your phone call and help you. And I took it. I took all the help that I could get. I had so many people helping me. I had my egg retrieval fell out on Shabbat, and I had to be in the city, and it was last minute, and I had to have all these arrangements done, and I had people doing it for me. I had advice when I needed it. I had people guiding me every step of the way. I had an angel from Shamayim giving me my shots, and I actually look forward to going to her house because she handled everything for me, and she would just explain everything to me every step of the way. Of course, Mrs. Mali Heber, every halakha question, which a lot of them were time sensitive, and she was there. No matter what she had going on, she answered every single time. Another thing that was my guiding light and my lifeline through the whole thing was the Rabbi, Alav Shalom, Rabbi Michael Heber's book, Urevanim. I got it through a care package along with many, many gifts from SBH Infertility that really comforted me, I have to tell you. I don't know what it is about the book. Whoever has it, use it. Whoever doesn't have it, get it, please. I don't know what it is. I guess it's the rabbi watching over us. But it saved me. I took it everywhere. I said the tefillot every day. I didn't go to a doctor's appointment without it. I never traveled without it. I mean, I wish I could show it to you. It's very worn. And I know 100% that my babies and my children, all of them, are built on those tefillot. Baruch Hashem, my children with the hearing loss are very successful. I can't complain. But my babies that were born afterwards, I mean, I don't even know how to describe the enjoyment and the gratitude I have for, and the, like, you know, to enjoy a baby that I could just take out and not have to stick the hearing aids on, and I don't have the therapies, and just watching them talk just so easily, something that I took for granted. It's really like, I know, and I know now, and I'm certain that I took the tools that Hashem put into this world, and I gave my children a very big gift. Thank you.
Thank you, Marlene, for highlighting so many things that you received that helped you during your journey, and that SBH Fertility also offers. The shots, the care packages, the support, the advice, the mentors. And I just wanted to bring up one thing that you and I spoke about. I know that you are now a mentor in our peer-to-peer program, and you coach women going through similar things, IVF for genetic reasons and so on. And could you tell us a little bit about that?
So obviously, I learned so much from everyone who helped me. I couldn't help but give it back. It helps me selfishly. It does help me, you know, to like know that I went through all this for a reason, to help other people. And I think that when people see that I have both sides, I have the children who were affected, and then I decided to go through with it, it gives them a different perspective. Like, okay, you know, like I'm able to, I don't even have to say it, you know, they're able to see, like, she went through it and she decided to prevent it. And it is genetics are confusing. Not always do you want to go through it, especially with something like this. You think maybe I could just, you know, stick it out and do it, but I'm able to give them like a perspective of, no, it's a struggle. It might not be the biggest struggle in the world, but that's what it's here for. Thank you.
Thank you. Okay. Last but not least, Barbara Cohen.
Hi, thank you, Rochelle and Elliot Franco, for hosting this beautiful event. Thank you, Rachel Tabish, Rachel Hazen, Gladys Hazen, and SBH for having me, and for all your help to get here. In September of 2021, almost 2 years after we got married, my husband and I decided that we were ready to start our family. We went in very optimistic that it would happen relatively fast for us. I was 23, so young. All of my friends and family around me got pregnant so quickly, I didn't assume that things would be any different for me. I naturally am a person who likes to control things, and around 3 months into trying, I decided to buy some ovulation tests to try and get a better idea of that timing. The first month I started tracking my ovulation, I noticed that I was ovulating very close to mikvah night. That month I didn't get pregnant, and I decided that I would continue tracking. I tracked my ovulation the following month, and that month I ovulated before I went to the mikveh. At this point I started to worry a little, so I spoke to my Kala teacher and a few rabbis, and we came to the decision that I would speak to my OBGYN and see if there was anything I can do to push back my ovulation. She told me that there are medicines you can use to push it back, but that wasn't something that she could give me. I would have to see a fertility specialist to prescribe me anything of that sort. Seeing a fertility specialist at 6 months into trying seemed a bit excessive, but okay, I would do what I had to do. When you walk into a fertility clinic, you can't just pop in and say, hey, this is my problem, I already diagnosed myself, and I just need you to give me the medication so I could be on my way. Once you walk in, most clinics and doctors will run a few general tests to see if everything with your reproductive system looks okay. They ran a few tests to check the eggs, sperm, hormones, and we then met with the doctor. The doctor told us that everything looked great, seemed that the ovulation timing was my issue, so he prescribed me with letrozole, which would help delay my cycle so that I can ovulate after going to the mikveh. About 3 months passed on the medication, and at this point we're around 9 to 10 months into trying. And I know that this seems like a short period of time, and it is, but anyone who has had any sort of trouble trying to conceive knows that each month is painstakingly long. I was trying to remain positive, but each month brings another heartbreak. You start trying the same time as a friend, and she's already 6 months pregnant. Everyone around you is somehow expecting or just had a baby, and it starts to become harder to be around people and go to events. Each time you hear a pregnancy announcement, you smile, but you ache inside that it's not you who gets to announce a pregnancy. I was starting to lose patience. I remember calling the clinic to ask if there was another step we could take to try to make this happen already. The nurse I spoke to let me know that the doctor said we can go ahead and try an IUI. We went in very hopeful. We were told everything looked great, and I remember thinking this could be it, dreaming of getting pregnant this month and when I would give birth. Unfortunately, that IUI failed and we were crushed. We were heading into the summer, still not pregnant and feeling very alone. I confided in very few people, and a friend let me know that I should reach out to SBH Fertility. I was hesitant because I kept telling myself nothing was wrong, partly in denial. Finally, feeling very down, I reached out and got a call back from Gladys Hazen. Up until this point, I felt that I was advocating for myself. None of the few friends or family I confided in knew anything about this world, its terminology, or what having trouble conceiving was like. It felt so good to finally talk to someone who just got it. She was my saving grace. I remember her telling me, "Wow, I can't believe you went through all of this already and you didn't call me." From this point forward, I called Gladys frequently, whether to discuss medical questions or just to vent. During one of these venting sessions, I remember telling her how unhappy I was at the clinic I was using, and we decided that it was a good time for me to switch doctors before we headed into more of this journey. I switched to a new clinic, new doctor, and he was incredible. Looking back, I think that walking into this new doctor was the first point I acknowledged that I was going through infertility, and this was something that I had to deal with. My husband and I walked into this new clinic, and after meeting with the doctor, we left feeling so much better. It was a great match for us. He understood what we were going through, and he made us feel less isolated. He suggested that before we get into further treatments, we run a few more tests that we hadn't done yet. He wanted to do further blood work and also check if my fallopian tubes were clear. Generally, when you walk into a fertility clinic, they tend to run the 3 big tests: the eggs, the sperm, and the fallopian tubes. The doctor found it a little strange that the other clinic didn't run that test, but he wasn't super concerned, and he wasn't really expecting anything to come up. He let us know that he thought we were dealing with unexplained infertility, but we'll wait until we get all the results to give an official diagnosis. The test used to check the fallopian tubes is called an HSG exam. It's the one that Flora mentioned. Fluid is entered through the uterus to check through an x-ray if the fallopian tubes are open. I finished the exam, and on the spot, the radiologist let me know that both of my fallopian tubes were blocked, that there was a 0% chance whatsoever of me getting pregnant over the last year. I left the office with my husband an emotional mess. I didn't really know what to feel. I'm upset because this is what's been keeping me from getting pregnant all this time. Upset and frustrated. The first clinic that I went to didn't run this test months ago, but I also remember feeling happy. Happy I was finally getting to the root of the problem. Happy it wasn't unexplained infertility, and happy that we had our answers. We got a call later that afternoon from the doctor, and I remember him being shocked at the results as well. The doctor explained that due to where the fallopian tubes were blocked, at the entrance of the tubes, that it was likely mucus blocking both of the tubes. This was overall positive news. He said I can go back to the radiologist that I just went to get the HSG, but this time he's going to do a procedure that he was going to, instead of the fluid or dye going through the tubes, it's going to be small needles trying to flush it out. Just a few days later, I sat there alone in the room, just praying this is going to get me the baby that I was praying so hard for. The procedure ended, and it was a big success. Both of my tubes were open. We were thrilled. We couldn't believe it. Our doctor let us know we can go about trying again naturally with no intervention, basically starting at square one. Physically, everything was looking great, but emotionally, I was nowhere close to where I was when I started. At this point, it's over a year, and I'm aching to be pregnant already. I distinctly remember feeling like I was in a race. Everyone around me is running, moving forward, but I'm still stuck in the same spot, still without a baby. SBH was so thoughtful, and after my procedure, they sent us out to dinner, and it was a great night for both of us to reconnect and have a moment of gratitude that things are moving in the right direction. The high holidays came and went, and I still wasn't pregnant. I had to sit through meals of people innocently asking hurtful questions or unknowingly making insensitive comments but I was trying to remain positive. After all, it had only been a month or two since we had just received such great news. I was struggling, though, and I continued reaching out to Gladys to vent. She was an amazing shoulder to cry on. She connected me with a peer who also gave me great advice. I remember complaining to Gladys saying, I should have been pregnant so long ago already, thinking I should have a baby in this grade instead of that one. I remember her telling me, don't worry so much about the months or years. When you look back at your kids, you're not going to be stressing out that the baby was born in the summer instead of the winter. Regardless, I was still sad. I wanted my husband to be a dad already. He stood by me so patiently through everything, and we were so ready. So about 4 to 5 months after the tubes were cleared, I was losing hope and patience. I was scared that it would never happen naturally. The doctor said we could solely start with infertility treatments again. As I sat in the office, I told him I would not start treatments again and put myself through the emotional and financial strain if I didn't know that my tubes were still open. He was a little surprised that I was worried. We had just opened them. We shouldn't assume they were going to close so fast. But I didn't want to be wasting any more time. So I went back to the radiologist to get another HSG exam. I sat through the procedure again to find out that one of the tubes had reblocked. This time the block was more toward the middle of the tube and not in a position to clear it out as we had done the last time. The exam was on a Friday, so I waited to hear from the doctor for the next steps. I was furious and disappointed I was back here again, back now in a worse position than I was just a few months ago. On Sunday, I received a call from the doctor that our plan was going to change from here on out. If only one tube is open, I could only get pregnant if I was ovulating on the correct side with the open tube. He recommended that we start with Clomid to try to get my body to hyperovulate in hopes to get an egg on the unblocked side. If I ovulate on the correct side, we would supplement it with an IUI to give the best possible chance. The doctor recommended doing that for 3 months and then moving forward with IVF, which would bypass the tubes altogether. IVF is always going to be a scary word to hear. When you're going through infertility, it's always comforting knowing that it's there, but it's just something that you hope that you never have to come to. I remember just going numb. I couldn't believe that this would soon be my reality. I had mixed feelings about this treatment plan. I wasn't super interested in going the hyperovulation IUI route for 3 cycles because it relied too heavily on the one good tube to stay open. The other tube closed after 4 months. Who knew how much longer this good tube was going to last? I didn't want to be wasting my energy, time, and money on something I wasn't so confident in. I decided with my husband that we would do the hyperovulation for just 1 month and from there go on to IVF. With one tube, the only way I could have a chance to get pregnant would be if I ovulate from the ovary near the open tube. That following month, I found out I was ovulating on the wrong side. I took the rest of the month to take a much needed physical break, but used the time to start getting ready for everything that was to come. We met with a doctor regarding IVF protocol. I switched off my parents' insurance and onto my work insurance, which had IVF benefits, which was a great blessing. Gladys connected me with a peer-to-peer mentor who had gone through IVF to hear about her experience. It was so helpful to hear from someone else who had gone through infertility, someone who understood. When going through infertility, it can be hard to talk to the people around you. Unfortunately, people don't always know how to say the right things or the things that you want them to say. I had a peer who gave me the advice of trying to find things to look forward to outside of getting pregnant. And I tried to do that. We took the month off to travel and find joy even in our sadness. We got back from our trip and met with the doctor again in order to move forward. The only thing we were waiting on was my period to come. My period was late, but not anything crazy. I was already spotting on and off. I remember the doctor telling me, just so you know, when you ovulate on the wrong side, there's a rare chance that the working tube picks up the egg in the other ovary. But it's less than 5% chance, so don't get your hopes up. We'll wait to see what the blood work is and where you are in your cycle. It was the end of December and Hanukkah, and I was down. The holidays are always hard when you're going through infertility. It marks another year passing with still no baby to celebrate with. My appointment was early in the morning, and that afternoon I received the best phone call of my life. I was pregnant with my Hanukkah miracle. I cried so hard, and I'm still constantly so grateful. This miracle is now my beautiful 10-month-old baby girl, and we are so grateful every day that she's here. I look back at that period of time with less sadness because so much good came from that heartache. I'm so grateful to Hashem that we have our beautiful daughter, thankful to SBH for their help and guidance. I learned so much. While going through that time, I had this notion that I was fine. I didn't really need to ask for help because I knew people in worse situations than I was in, especially sitting in a clinic when you watch a million people around you. But this was so untrue in so many ways. SBH is so helpful no matter how big or how small the issue is. And throughout my time talking to Gladys, I was never made to feel like what I was going through wasn't hard. I was allowed to feel the full force of the pain that I felt. The struggle I felt in that moment makes me be the most appreciative for where I am in this moment.
Barbara and I spoke so many times, but the Hanukkah miracle gets me every time. And I think next year I shouldn't wear mascara. But anyway, Barbara, after you cleared out your fallopian tubes the first time, and then you mentioned that the doctor told you it was time to
consider more fertility treatment, and you insisted on going for another HSG test to check the fallopian tubes again, you caught another blockage. And so I just wanted to ask you to talk a little bit about trusting your doctor, but also trusting your own instincts and using them to advocate for yourself.
Yes, definitely the biggest thing I learned is you know your body better than anyone, and you know yourself. And I just kept trying to trust my gut where it was telling me. And I remember the doctor even being surprised when we found the blockage. He was shocked that he couldn't believe there was actually something there. But you know yourself the best. And I also learned my lesson the first time around. They didn't check the tubes before I went into the IUI. I felt like I was a little bit naive the first time around. And I was like, I'm not wasting the money or the time without really giving myself that clarity in my head. I didn't want to go into anything without my head being clear that everything was looking good.
Thank you all today for coming and for sharing in our journeys. It's very therapeutic for us to share with you, and we hope that we helped you by giving you knowledge and insight for you to either seek help for yourself or help other family and friends going through infertility. We have a doctor's panel starting at 2 o'clock. Make a salad, come back if you'd like to hear it, and thank you for being here today.
So excited to be here today. I also can't believe who's sitting next to me. I put a little thing on Instagram, the celebrities are coming. No autographs. I'm just really, really excited to be standing next to these amazing doctors who have given up their time to us today, and I'm so excited to hear from them. Full disclosure, had my own baby 4 months ago with Dr. Barber's practice. And so please excuse me, half of my breed is mostly spit up and milk and other things that are not doctor related. But so privileged to be standing before you celebrating 5 years of SBH Fertility, excuse the number, this incredible, cannot believe how far we've come. Somebody was saying, oh, tomorrow's your SBH wedding, which is like a joke that I've been saying year after year, so I don't know how she knew that. But I was like, no, I'm at the honeymoon stage here. We have the doctors coming. What have we accomplished in 5 years? Over 1,000 couples have been helped by SBH Fertility. Currently, close to 200 active cases, currently, right now. And very exciting, this year we exceeded celebrating over 200 births. Phenomenal. We are here for you no matter where you are on your fertility journey, whether you're just starting out or you are right in the thick of it. There is no phone call that we turn away. Each one of you that reach out is like family to us, and I hope you're getting that feeling today. We help women across a full spectrum of maternal and reproductive needs, and we do so with the love and care that you each deserve. We are privileged to do that, and SBH is just an amazing place for us to be able to house this incredible mission, and it grows each year and each day. And yeah, I'm just excited to get started here today. I don't know, do they need introductions? We have Dr. Andre Rebarber, Dr. Victor Grazzi, Dr. Victor Dweck, Dr. Howie Kurtz, and Dr. Joseph Buganim. There's a few people in the crowd who I know are willing to name their third son Victor. Not so convinced about the name Andre yet. But maybe we'll get there after today. You never know. So I want to just kick off today with a couple of questions. We're not really opening up to the crowd, but we'll see if there's time. So Dr. Kurtz, first question. What are some things I can do before getting pregnant to help facilitate a healthy pregnancy? Do I need to visit my OBGYN beforehand?
So before I start, I just wanted to thank the hosts, Rochelle and Elliot, for having this lovely event. I probably know them 35 years maybe. Elliot was my co-counselor in camp when I started this medical journey, so it's only appropriate that I'm back here. And I wanted to thank SBH for having this wonderful branch of the organization. It's vital and important. And I want to thank all the panelists there also. I know personally are great doctors also, not just sort of behind the scenes. The way I would look at it before you're trying to get pregnant is, the example I would give is, if your husband was having an appointment at Walmart, he would take the time and prepare a lot for it. There's no difference if you're planning to have a baby that there should be some preparation involved. So, it's very important. I think it's easy for someone who's we're more likely to catch patients maybe in their premarital visit or so, or maybe if someone had a problem to come in, but there's also that whole in-between area of people who are in between babies and maybe busy with their lives and so forth, that neglect taking care of certain things are important. So if we see someone for a preconception visit, we're really trying to focus on things that may be detrimental to both the mother, the baby, and the pregnancy and altogether. And really, it's not anything that's that intricate. So you really have to take a good history. So starting from age and things that may be important that come across with age. So whether it's genetic issues or risks of blood pressure or diabetes, patients' backgrounds are important. So we offer genetic testing depending on your backgrounds and so forth. Patients' weight is important, whether they're underweight or overweight. That has implications. What you have, what kind of job you have, what you're exposed to, and so forth. And obviously also different medical problems. So if someone has asthma, someone has anxiety, diabetes, blood pressure, and so forth, it's important to make sure that the medications you're taking are safe for pregnancy, that everything's under well control. It's also a good time to go over prior obstetrical history. So if you had a cesarean in the past, or you had this complication and so forth, what things you could do in the interim that may help reduce and mitigate the risk of that happening again. And I think it's also a good time just to go over what to expect during the pregnancy also. So, if you have blood pressure, what may you be looking at during pregnancy and so forth. And then obviously also, you can address also, sorry for saying also too many times. But you can also address if you're having difficulty to get pregnant and so forth. So I think it's a crucial visit that many times is overlooked. And I think it's an important one to get, particularly for that niche of patients that had one or two easy kids and so forth, and then sort of forget about it and too busy.
And often the OBGYN is the only doctor that a lot of women are seeing in their reproductive years. So that's like,
correct.
You're almost the primary care physician in that way.
Correct. Right.
Dr. Rabarber, what happens if something shows up in the genetic testing and there may be an issue? It's live.
It's on.
Yeah.
Hello? Okay, good. Thank you so much for inviting me and to the host.
This was Dr.
of
Rabarber's
SBH.
idea.
Yeah, thank you. I didn't think it would be on today because as I just texted my wife, it is our anniversary today. So she said, so you're spending it with 500 other women. But I did want to thank all the panelists. They're amazing group of doctors. And so may wonder, what am I doing here? I think that the government called SBH and looked at the diversity, equity, and inclusion. And I'm the Ashkenazi DEI accepted in the Sephardic panel. But anyway, as far as genetic testing goes, I think that's one more very important thing to think about in the preconception period. In the preconception period, people we'll do a full screen of your medical problems, the medications that you're on, how safe is it to become pregnant. There's often a lot of questions. Some people are on medications for depression, things like that. Those are all quite safe to use in many ways. And so that's important in the preconception period. But additionally is your genetic screen for hereditary genetic conditions. And people forget. So genetics are a very complicated thing nowadays because we have hereditary genetic disorders and then there's spontaneous mutations or errors that occur during the pregnancy itself. And so we screen for both of those. But what you can take care of before you conceive is actually to look for carrier status. So if you remember all from biology, everybody took biology and remember Mendelian inheritance, autosomal recessive, dominant, things like that. So each of us are carriers of something, right? So we're recessive carriers for certain conditions. And so those are important to identify before you get pregnant because then you know if you're a carrier, you would check your husband. And if they're a carrier too, then you would know to actually know what your risk is, which is about 25% chance of an affected offspring if it's autosomal recessive. And if it's X-linked, that means males could be affected, like Fragile X, more than females. So it becomes relevant because you can avoid those conditions if you do IVF and PGT, and we can test the embryos before we put them in. So you don't even have to worry about it while you're pregnant because you know ahead of time. So for hereditary genetic conditions, you're looking for these recessive traits. Now, as far as during the pregnancy, we screen for a lot of what we call spontaneous errors that occur. Now, these errors could be chromosomal, genetics, or what we call microdeletions, where there's a chunk of DNA missing during replication. These are all now done through blood tests. The blood tests actually can check for these genetic conditions by looking at fetal DNA, which is really placental DNA fragments that's circulating in the mother's bloodstream. So think of how amazing the technology is that the placenta constantly is turning over, cells form, die, and those cells actually spit out DNA from the placenta into your circulation. It lasts about 30 minutes, and then you just pee it right out. So we can take advantage of that by drawing a blood sample and then analyzing those fragments of placental DNA for these genetic conditions. And they're quite accurate. It's about 99% its ability to pick up Down syndrome. It's not as inaccurate as the older tests that were done in the 90s or so on, where they did these soft markers or so on. No one's using that anymore. So that becomes relevant, those blood tests. Microdeletions a little less accurate, but still relevant for certain genetic syndromes that we can identify, something called DiGeorge and so on. And then there's something called Vistara, which is a sequencing of the DNA of this DNA that's in the maternal circulation to look for autosomal dominant traits like dwarfism and things like that that's coming around. The incidence for some of these conditions are somewhere in the 1 in 500 to 1 in 1,000. So they're pretty rare. But if you think about it, there are 4 million births in the United States. And these are random events that occur regardless of your family history. They just occur as a mistake during reproduction. We can't do too much about most of them. But again, the issue is that would we want to know? Sometimes you'd want to know where to get this special care, the pediatric care. For example, a syndrome called DiGeorge. DiGeorge itself can be associated with hypocalcemia and other conditions in the newborn period that could result in seizures and other things. So you'd want to know because you can get the baby right away care in the NICU and things of that sort. So we don't always do it to find out stuff that we would stop a pregnancy, but we do it so we can get the best neonatal care and outcome for pregnancies as well. So genetic testing is complicated. It's important. I usually spend a good hour talking to patients about these tests. The variety of tests that are available, how they're obtained implies how accurate they are. And then you have invasive testing. So traditionally, these are all screening tests. And if you have an abnormal, we do invasive testing. And invasive testing has to do with a chorionic villus sampling, where we biopsy the placenta, or an amniocentesis, which is a needle into the sac. That is diagnostic testing. That is 100%. And we can test for even more things than the non-invasive that I just highlighted. So it's a little complicated. I don't know if I answered it in 15 seconds or less. But hopefully that was helpful to give you a sort of a synopsis or an idea of the testing that's available nowadays.
Awesome. I did test positive for some things, but my husband didn't, obviously, because he's perfect. Dr. Bugadam, What type of GYN issues may come up that could potentially cause fertility issues, and how do you manage them as an OBGYN?
Thank you. First of all, again, thank you to the host, and thank you, Rachel, for having me. Thanks to all the panelists. In terms of diversity, equity, and inclusion, you're the only Ashkenazi guy, I'm the only DL doctor. So anyone needs any GYN care in Jersey, I'm your guy. So essentially, going back to Dr. Kurtz's point about the importance of preconception counseling, it may be the first time you're meeting an OBGYN where you're saying, I want to get pregnant the next year, let's review things, make sure that I'm in a healthy state to get pregnant. But going along that, this may be a doctor who you're already seeing for GYN care annually. And so there are certain conditions that may or may not be picked up on by your GYN that can impact fertility. So talk about some of the common ones, something like PCOS. So PCOS is a condition, common GYN condition that is what we call hyperandrogen. So you have elevated levels of hormone that are sort of like the male hormone in a sense. They can cause things like deepening of the voice, excess hair growth, cysts or follicles on the ovary where it gets its name, polycystic ovaries. And then most importantly, it can cause irregular ovulation and periods. So reliably to get pregnant, you really do need regular menses, which makes it the easiest to get pregnant. If you can know when you ovulate, you can get pregnant most of the time. With PCOS, it's difficult because you may have irregular menses. Now, there are treatments for that. Treatments to, first of all, lower some of the risks of PCOS, which are what we call metabolic. So things like high blood pressure that can be associated with PCOS, obesity, diabetes, and insulin. So a big part of PCOS is insulin resistance too. So all of this can come up in your GYN care, in your routine care, and things that can be addressed prior to pregnancy or even to help getting pregnant. Sticking on PCOS for just a moment, there are certain treatments that can be done basically in a fertility perspective to help. We talked about weight with PCOS. Studies show that as little as 5% weight loss actually can help with regular ovulation. People hearing now about Ozempic, a very timely medication that we're hearing a lot of in the news. Maybe some of you have used it or know people who are using it. And we're seeing people actually get pregnant from Ozempic. And the reason is because the weight loss is decreasing the insulin sensitivity and ovulation is becoming more regular. So things like PCOS is something that might be picked up on by your physician and tests can be sent for that. Something else that's common in terms of someone has pelvic pain that's chronic is endometriosis. So very common condition in GYN that's underdiagnosed, unfortunately, is where the glands, which are normally just in the lining of the uterus, can end up outside of the uterus. So near the ovaries, in the tubes, can cause scarring in the tubes and pain during your periods and even between periods. So that is a common cause of infertility as well. And again, treating the endometriosis could be a whole hour topic just on endometriosis alone, but surgical treatments, medical treatments, which can help to improve fertility in the setting of endometriosis. There's also uterine fibroids, which are benign muscle tumors or growths that can happen in the uterus that can impact the cavity of the uterus. Again, those are things that, as general OBGYNs, we do work with the fertility doctors closely. So the ones that I work with will say, we have this patient who either has scarred tubes that probably for IVF should be removed prior to IVF, or fibroids inside the cavity of the uterus, which we can remove surgically in the operating room. And so these are GYN conditions, they go hand in hand. So I think it just speaks to the importance of preconception counseling that Dr. Kurtz was saying, but also just regular GYN care and somebody who you feel comfortable with letting know your symptoms so that things can be worked up if necessary.
Awesome. And a warrior person here. Dr. Dweck, I wanted to ask you about other issues in which a woman may have irregular periods or possibly skipping periods, how you might handle that in your practice.
For that great talk. PCOS is definitely one of the more common reasons for a woman not to get her cycle regularly, but there's another type that we see a lot, a little bit more common in a community as ours where we value appearance. Sometimes the girls, the women, end up exercising and dieting enough that they get to below their ideal body weight, and that can result in something called hypothalamic amenorrhea, which is basically the pituitary gland not producing enough hormones to give you regular cycles. Now that may not be such a big issue before marriage, but after marriage, if you're not getting your period for 2 or 3 or 4 months because of that, then you're also not ovulating for 2 or 3, 4 months, and it makes it just harder to get pregnant. So, that we see, and we encourage a healthy, balanced diet and cutting back a little bit on the exercise, maybe gain a few pounds, try to keep the stress level low, and that could help them resume their regular menses.
You also mentioned, we spoke earlier this week about halachic infertility. Can you speak a little bit to that?
Yeah. So it's not a medical problem. This is somebody who gets their periods regularly. It's just that it's a little bit more on the frequent side. Instead of, let's say, every 28 to 30 days, they may get it every 24 to 25 days, which is not a medical problem. They're ovulating, they're normal and healthy, but they're ovulating right before they go to the mikveh. And that makes it essentially impossible to become pregnant. So there are ways to help delay the ovulation, and we have those techniques, essentially giving extra estrogen in the first part of the cycle, or people who may be a candidate, giving Clomid that can help delay ovulation, and that's all they might need to get pregnant.
Awesome. Thank you. Next question is for Dr. Razi, I'm sorry. I keep hearing that first trimester pregnancy loss is so common. What are my options if it happens to me?
First of all, thank you. I got to know Rachel and the rest of the team when I had the true pleasure and honor of serving as SBH president about a decade ago, and to see this division grow is just so heartwarming. And as I'm driving out here from my Brooklyn office this morning in Staten Island traffic, worried about getting here on time, I pull up and there's nowhere to park, and one of my cardinal rules is to never valet. So I'm thinking, how is it that so many people are coming out? And I realize that this division of SBH speaks to the very core of who we are as a community. We value family. We value the passing on of tradition. And there's no more explicit way of fulfilling that goal and that dream for each of us but to raise children. And the concept of infertility and the issues that are discussed were ones that were really not addressed, at least not in a public forum until recently. And I think your group deserves a tremendous sense of gratitude for that. As far as my fellow panelists, Dr. Barber made the joke about being the Ashkenaz on the panel. He recently bought a home out here in Long Branch. He takes care of many women in our community. So he is about to become officially certified. But I will teach him how to dance if you can teach him how to cook. So, having opened up with the concept of family being really one of the main core foundational values that we were all raised with, it's a bit odd for me to speak about the topic of pregnancy loss, but it's one that should be addressed because it is rather common. And I have had countless numbers of experiences in my own office where someone has a first trimester loss, and I try to share with them that despite the sense of loss and the setback and the emotional turmoil, that it is so commonplace, it does not speak to the future being bleak. And inevitably, when they come back to see me thereafter, they say, yeah, I didn't realize it happened, but it also happened to my sister and to my cousin and vice versa. It's something that we really, until recently, didn't speak about. There's no structural, ritualistic approach to pregnancy loss in our tradition. And so to some extent, it's really something that people felt all alone about. Nonetheless, it is really extraordinarily common. Overall, the risk or the incidence of first trimester loss, I'm defining first trimester distinctly from the second and third, which is a whole different category. First trimester, first 13 weeks or so, the incidence is somewhere between 10 and 15% of all recognized pregnancies will end in pregnancy loss. And it's related to the age of the woman. It's probably around 10% when you're in your 20s and as high as 50% or more when you're approaching the mid-40s. So it's quite common. And since it is so common, it's something that I always tell. Sometimes I'll have a woman come in and she'll be having her 7th or her 8th child, and she'll have a pregnancy that's not going to continue, and she'll ask me, how could this happen to me? I have 7 children at home and it never happened before. And I explained to her, not only you older, but It's a matter of the statistics. If you're like my patients in Manhattan who can only have 2 kids, you can go through your life never having experienced a pregnancy loss. But if you're from a community where a larger family size is valued and part of your desired family size, then probability is somewhere along the line you'll experience a pregnancy loss, or at least the odds are pretty high about that. So once the diagnosis is made, we really have 3 approaches. And probably more than anything else that we do in obstetrics, it really should be patient-centric. It should be up to what the woman and her husband choose is best for her, because the 3 options, for the most part, are pretty equivalent in terms of their safety and their degree of success. So the first one, which is what we call expectant management, which basically means we're going to try to wait for the pregnancy to pass on its own. This is really only an option in the first trimester. Earlier in the first trimester, preferable. Later in the first trimester can be a little bit challenging. It's difficult to wait because we don't know when and if it'll happen. It can take quite some time, and it's very difficult to sit knowing that you're pregnant, still feeling pregnant because you have the hormones in your body, but knowing that the pregnancy is not a viable pregnancy. It can be very difficult waiting for that to happen, particularly with the unpredictability of its time course. So what I generally do with the patients that I see is we'll set a somewhat arbitrary deadline. I'm going to wait a week. I'm going to wait 2 weeks, and I'm willing to wait that length of time to see if I am able to pass the pregnancy on my own, and if not, we'll go to another one of the alternative treatments. The advantage of the expectant management is it's successful quite often, and you can avoid a surgical procedure, and you can avoid the whole trauma of having it be a medicalized experience. The downside of it includes, as I mentioned, the uncertainty of time, as well as the fact it can be frightening to be at home and to be miscarrying on your own without someone by your side. But that is an option. Second option, which was the traditional option for generations, was a surgical interruption where we would do a D&C, either in the hospital or in the office. Very specific and unique advantage to that approach is it's defined. You're scheduled Tuesday at 10 o'clock, you have the procedure done, it's over. Disadvantage is that it carries with it the need for a surgical procedure, usually with some sort of sedation or anesthetic. And as with any other surgical procedure, there is a small risk either of infection or bleeding or whatnot. But for some women who need that definitive, time-bound certainty, it's an option that can and should be offered. The most recent one, which is not particularly recent, but the most recent of the 3 that I'm discussing, is what we call medical management. We now have medications that women can take that will help them to more successfully pass a non-viable pregnancy without the need for surgery. There are various different protocols for how to do that. The most successful one involves 2 medications, which can be administered orally, can be taken at home in the privacy of your own home. The advantage of this technique is that it's highly successful at avoiding surgery, but again, it carries with it some of the disadvantage of knowing that you're at home and you'll be miscarrying, and what does that entail? A very small number of those women who either choose option A, expectant management, no intervention, or option 3, medical management, if they have excessive bleeding or if the pregnancy doesn't completely pass on their own, may end up needing a D&C anyway. But these 3 options essentially are considered, for the most part, equivalent in terms of their safety and their rate of success. And it's critical to have that conversation with your patient when you're offering all 3 of her. And you'll see, so interestingly, some women who will absolutely definitively pick option A, some will pick option B, and some will pick option C. And we're grateful that we have those 3 options. I certainly hope that they're options we don't need to employ often, but when the situation arises, as unfortunately it can and will, we have choices that we can offer.
Thank you so much. And very, very important topic that we get calls about all the time, unfortunately or fortunately, from women who are having a miscarriage in any trimester. So I appreciate the explanation, because I think a lot of the time the women are like, I'm not sure, what are my options? So we're able to sort of give them those pros and cons to each. Dr. Kurtz, I wanted to ask, do I need a full workup after one first trimester pregnancy loss? And what if it happens again?
I just want to circle back to something Victor said. So one of the things that I would look at after, either one. Victor is old family. Victor is my old friend from Bays High School, so either one is fine with me. But one of the things that I would want to look at is when I'm picking a choice and moving on is there anything I can learn from this past pregnancy that will help prevent that in the future? So one of the advantages on the D&C is that you can test it for genetic studies. And so that may give some closure to it. So if there's something genetically abnormal, which is usually more of a random thing, at least we can give some sort of reason for it moving on, where maybe someone doesn't feel that's going to happen again and so forth, whereas if we don't have a reason. So that would be one other benefit from there. In terms of one early miscarriage, you don't necessarily need a workup. As Victor said, it's not uncommon to have miscarriage, unfortunately. Well, technically, I would say under 10 weeks. But we have many of them who will come in and never see a fetus, or what we call a missed abortion, which didn't even make 6 weeks or so. But if you had a couple, then the different things you'd want to look at is some people, and it may be a bigger issue for a little further along, but some people will have tendencies for their blood to thicken or clot, and so there's what's called a thrombophilia workup. There could be a genetic workup also, really just checking the chromosomes of both, a simple blood test from both parents. Some people, a bit controversial, will maybe watch progesterone levels also in future pregnancies. Sometimes you may get a special sonogram, saline sonogram, to look a little better inside the uterus to see if there's anything inside there that may be causing any issues with pregnancy. So those are really the main things. The other thing that, which I think would be important to our community also is, in the end of the day, I happen to learn the halachot of Nida, and one of the things we learned, the Gemara says, is that there's 3 partners in creation. So you really have 2 fathers. You have the father, the mother, and God. And so you have to keep that in mind also, is that we can't always explain things and so forth, but to keep your faith in God, and hopefully that'll help give some comfort also. So those are the different things that I would remember. And as an obstetrician also, after anyone has a miscarriage, you have to be, and I think we all are, a little more sensitive to it. So these patients will want to be seen a little more frequently. They may just, even though you tell them come back in a month, they end up showing up 2 days later, just want to check the heartbeat and so forth, and that's fine. Maybe until they feel a baby and so forth. But that's pretty much what I would answer.
Thank you. I'm now noticing I am all of these things. Endometriosis, inherited thrombophilia, all the good stuff. As Dr. Barber has said, I have the real thrombophilia because I'm homozygous, back to 5 1 in a million. Thanks, Esther. I'm joking. My sister figured it out. I wanted to ask the next question to Dr. Barber. What is the difference between a normal, at-risk, and a high-risk pregnancy?
Read the book. So
it really is good.
It's a good book, and Fox is one of the writers on it, and it talks a lot about high-risk pregnancies. But like, for example, miscarriages that we were just talking about, people think they have one miscarriage, they're high risk. So I've always stressed to people that miscarriages are almost a disease of our technology than it is in our time. We're identifying early pregnancies that otherwise previous generations never had to deal with, ever. And emotionally, that is taking a toll on our young women, because you identify, when you see that little blue line, an infant. But there's a lot of things that have to take place before that infant is born. And so you have first trimester losses are chemical pregnancies, where you just see a hormone rise and then it drops. There's also what we call anembryonic pregnancies, where there's an empty sac but no embryo formed, where they're usually 90% genetically abnormal. And then you have fetal demises, embryonic demises, which has to do with under 8 weeks, the embryo's forming. And so, for example, if you think of how complicated human beings are to form from one cell in the body that differentiates the highest level of molecular development and what we call de-differentiation of cells, the cells that start to decide, I'm going to be the eye, I'll be the nose, and then all of those sensory organs form from that. It's mind-boggling, and it's humbling, because we know nothing. And that's where I agree with how God comes in, because as much as we have science, we do not understand this very complex process. And any little thing that can be a mistake, an error during DNA replication, causes miscarriages. And miscarriages are a normal part of reproduction, because I always feel it's from above a way to tell us this was not meant to be. This was going to be a very sick child, and it's not the right thing. Because again, from a human reproduction point of view, humans are very inefficient in reproducing. We have 9 to 10 months of gestation. That's long in reproductive time. And we only have one baby at a time. And the goal of reproduction as a mammal is reproduction. The goal of having babies is having babies. But if you make babies that cannot reproduce, you used up a lot of important biologic time. And so miscarriages don't make you a high-risk pregnancy, certainly not one, and even 2 early losses, depending on how they occurred and what type, becomes less relevant. Like if you have 2 chemical pregnancies, early losses with just a blood test, most of those are just a sign of, you know, a conception occurred, but it was probably very abnormal. And we know 90% of early losses under 10 weeks are abnormal embryos, whether it's chromosomal, which is 50%, or the other 40% where you have single gene mutations, other errors of DNA, deletions, duplications in the genome itself. So there's a lot of good data now suggesting that all those early losses, even when we see a heartbeat, but most of the time without a heartbeat, they're abnormal embryos. That was meant to be. And it's not you. And that's the message. It's not what you ate. It's not that you exercise. It's not bed rest is going to help. Very few activities impact on causing miscarriages. Very few. Trauma, if you got hitting, belly, trauma, motor vehicle accident, drug use, maybe. But outside of those rare things, or medication, certain medications, very little actually will cause miscarriages in early. If it's a healthy embryo, it's likely to stick with it. Now, there are other high-risk issues besides miscarriages. We get into medical conditions, right? So there's certain medical conditions that put you at risk in the pregnancy. But if you're well controlled, you're not that high risk. So for example, if you have pre-gestational diabetes, so you have diabetes before pregnancy, you are at risk. We have a whole protocol of how we manage these pregnancies. But in this day and age, most people have really healthy pregnancies and everything goes well if they're well controlled and managed during the pregnancy. Same thing with things like lupus or certain autoimmune disorders. Those become at risk, but not necessarily high risk, chronic hypertension and so on. So there are medical conditions that might affect you to be high risk. Then there's your obstetrical history that makes you high risk. If you've delivered a preterm baby, you're more likely to have another preterm baby. If you've had preeclampsia or toxemia, you're more likely to have that again happen. So we do some measures and things to try to optimize the outcome in surveillance and some medicine sometimes to treat that. Again, at risk, not high risk. And then you get into an actual high risk pregnancy, which is women who have artificial valves replaced on full anticoagulation, metal valves. We don't use them much anymore, but they do. Or somebody who actually had a stroke in pregnancy currently, and we're trying to decide about anticoagulation or not. Or cancer in pregnancy. We just had somebody in our practice got diagnosed with breast cancer at 21 weeks. So that's a high-risk pregnancy because we have to give her chemotherapy during pregnancy and manage her and continue the pregnancy, and what do we use and not. So those are sort of our elite high-risk pregnancies, mostly exclusive to people that are trained like me as maternal fetal medicine specialists. And the at-risk pregnancies, or not at all, those are general OBGYNs, which are specialists. So the board looks at an OBGYN, a board-certified OBGYN as a specialist, and I'm a subspecialist. And then there are people who do obstetrics that are not specialists, whether it's a midwife or a family practice person. And in a lots of parts of the country, they don't have people like me. They use OBGYN specialists to be the consultants for the high-risk pregnancies. And in regional areas, again, in the Northeast and others where there's a lot of MFMs, we become the consultants for high-risk pregnancies or at-risk pregnancies on how to manage. 90% of board-certified maternal fetal medicine specialists do not do deliveries in the United States. 90% of them do consults and ultrasound, and most of them do not do deliveries. And OBGYN delivers these pregnancies, and they work with an MFM in managing some of these complicated cases. In New York, there are a couple of us that still do. I still like it, so I get involved, but I don't have to. So, but I enjoy it. So that's sort of it. The training as an OBGYN is, so people understand, is there's 4 years of medical school, 4 years of residency. You take a written exam, and then you have to pass an oral examination nationally to pass that to become a board certified OBGYN. That's on top of 3 exams that you take to be a licensed physician in the state. As a maternal fetal medicine specialist, you have 4 years of medical school, 3 licensing exams, the same 2 exams to be an OBGYN, and then again, you do it again, because you're just a glutton for punishment, and it's 3 years and another 2 exams, written and oral exam, to be a subspecialist. But our training does not make us to be better doctors to deliver babies. We're not, that our specialty focuses on prenatal diagnosis, ultrasound. It's not a surgical subspecialty, it's more a thinking specialty. We write papers, we do research, and we kind of think through problems, work on various research ideas and things like that. So that's a little bit about at-risk, high-risk, and then training when people use MFMs or OBGYNs and how people are referred. And again, it really depends on your OBGYN and the maternal fetal medicine doctor, because there are some MFMs that Dr. Grazi would say you would definitely not want them delivering your baby because you don't do it. Because you're very skilled. So it's not about these labels, it's about the skill set of the physicians and about who knows what they're doing and not, and who likes doing obstetrics or not.
Can I add something to that, Rachel?
For sure.
So I just want to go back, I mean, when Victor Grazi is the youngest one of us here, but I can go back to my time. But back in my time, I went to school with Victor, there were really almost nobody going into medicine from that community. And we're very fortunate that we have over here a panel of community physicians who are in top-notch hospitals, have top-notch connections, who are very busy in doing deliveries and high-risk deliveries and everything. And really care about people in the community. That's why we're here. And so there's, and if any issues come up, we are totally fine in taking them and trying to fit patients in whenever we can and so forth. So there's, I think we're at a time now where for the community, it's a very lucky time that you have for this field. So there's no reason to look anywhere else because we really can do anything that the community really needs. And it could be from the most low risk to high risk and so forth. And it's really a good time for our community from that standpoint. And I'm sure it applies to other fields also, but I can speak for the OBGYN field.
I was going to say, Dr. Robert did not make the MFM track sound very appealing.
I think I don't want to omit along the lines of what Howie said. We have a number of extraordinarily talented young women in the community who are either obstetrical nurses or nurse practitioners or PAs. And if any of you in the audience have a family member who yourselves are involved in any of the medical or medically affiliated fields, I don't have a book to plug, but I have another SBH division to plug, which we started this past spring, which is the Florida Medical Network, which is meant to be just a way of getting to know one another, help one another, mentor one another. Dr. Buchanan called me, I don't remember how many years ago. He was a medical student who was interested in obstetrics, and for the last several years we've been in touch, and I'd like to think that I've had an impact on his career in a positive way. But I want to formalize that structure for the young men and women in the community who are in healthcare fields, not just medicine, but nursing, PA, et cetera. So if you know anybody in the field, have them call SBH, register for the Sephardic Medical Network. There's no obligation. It's just a way of helping one another, the way the businessmen in our community have done for generations. So sorry for the segue, but
good. It's good.
The door.
No, I just have to follow up. The answer is yes. You have had a tremendous impact. Actually, almost everybody on this panel has at one point or another I've spoken to as a mentor. So it's an honor to be a part of this panel. Thank you.
The only other thing I would add is that in our ultrasound unit, we always have rotations of medical students or residents or sometimes people who want to go to medical school that they actually work 2-3 months on research projects with us. And so we have a lot of academic opportunities for young people that are interested to go into medicine or be in our office, and we welcome that. And we enjoy teaching our whole team, really, and there's you know a lot of them, but they're wonderful and they're really kind, and one of the things that we know is we really want to pass it on to provide good, compassionate care to people in an academic way.
Okay, I want to ask Dr. Buchanan quickly about sort of this TMI type of world that we're in, right? Like, how do you find the balance between knowing too much about a pregnancy and, you know, causing unnecessary alarm and also just doing your due diligence?
Yeah, I think you mean medically, just fine.
Yes, my baby's measuring small.
Right.
I have too much polyhydramnios.
Right. So I mean, of course, Dr. Barber is an expert on this, but I can comment. I mean, as a generalist who works closely with high-risk obstetricians all the time and caring for my patients, there is definitely a fine balance, right? So sometimes I have patients who come to me who I discuss what the recommended ultrasounds are throughout pregnancy, and they're very surprised. What do you mean I'm not going to get a scan every single time, right? Or what do you mean we're not going to do growths frequently? So there are really two main reasons why over-medicalization of pregnancy is not a good thing, just in general. So practically, for instance, growth scans. So as many of you may know, you get growth scans, check on the growth of the baby. Now, if that's done too frequently, actually it becomes less accurate. So you really can't have a growth scan more frequently than every 2 weeks, because inherent in each growth scan is some margin of error. So we say there's a fudge factor one way or the other. If you get it more frequently than every 2 weeks, you're really not tracking it appropriately. That's one reason. But the other thing is that whenever you over-screen, whether it's in pregnancy or in GYN when it comes to pap smears, and you're doing things that are really more than the guidelines recommend, you're bound to, whether it's mammograms or anything else, you're bound to find something eventually if you look hard enough. But that thing may not be significant. And then it leads you down a rabbit hole, whether it's from a GYN perspective or obstetrics, in terms of worrying about things that may not even exist if you had just waited. So, I mean, I think in our day and age, technology is incredible. When we are monitoring, for instance, a growth-restricted baby, a baby that's measuring less than the 10th percentile, absolutely, we need to follow that baby as, per protocol. We follow the growths. We check on the blood flow through the umbilical cord to the placenta, and these are all very important things to let us know if this is just a small baby because of statistics, or if this is a small baby because there's something pathologic or abnormal happening with the placenta. But I think it's important to know that sometimes a little bit less is more when it comes to these, when it comes to surveillance.
Thank you. Next question for Dr. Dweck. I'm so excited to hear. What are some things that someone could do to lower their chances for a C-section?
Well, thank you, Rachel, for inviting us and organizing this event. Okay. Thank you, Rachel, for organizing this wonderful event. And Rochelle and Elliot for hosting us. And actually, I see so many familiar faces. Thank you for the audience for coming out and completely filling out the stadium. Now I know how Donald Trump feels. But my goal today is to empower you with some knowledge on what you and your doctors can do to help lower your chances of ending up with a C-section, to increase your chances of a natural delivery. A lot of you may not know this, but in 1970, the C-section rate was approximately 5%. And it's steadily gone up, and now it's at least 30%, and in some places a lot higher. What that actually means also, within each individual hospital, you'll have a range. Some doctors as low as 5 or 7%, some as high as an outstanding 50 to 60% C-section rate. Even though the World Health Organization and the American College of OBGYN that sets the guidelines have said that it's risen to a level that they consider unacceptable. But what's so bad about a C-section, you might ask? Well, it's not bad if it's necessary and if it's done for the right reason. In fact, we're so lucky to have this procedure because it could actually be life-saving for both mother and baby. But a lot of them are, I would consider, avoidable. And it is still considered major surgery. And the inherent risks of major surgery are higher chance of hemorrhage, higher chance of infection, more risk of adjacent organs that could get injured, like the bladder or the intestines. It's just a harder and longer recovery. Plus, it increases the risk of certain complications in future pregnancies, like there's a higher chance of the uterus rupturing in labor in future pregnancies, which put potentially the mother and baby at risk. Also, we live in a community where we value the size, and we want the option to have as many children as Hashem would bless us with. So if you start out with a C-section, it does raise the risk of the next one and the following one, and possibly all the children would be delivered by C-section. And there is a relative limit to how many C-sections you could have. So ultimately, it could lower the size of your family. But, what could be done about it? What could be done to lower the chance of C-section? So I feel the best strategy is to work very hard to try and lower the chances of the first pregnancy ending up in C-section, because it kind of has a life of its own. If the first delivery is a natural delivery, you may very well have all your deliveries natural with fewer risks and complications. But if the first one is the C-section, it just raises the risk of the next one and the subsequent ones ending up with C-section. So, I'm going to share some of the things that I've learned and experienced over the last 30 years in this field that that you can do, and you can help discuss with your doctor about ways you could lower your risks. So what can you do? The first thing is, even before you become pregnant, I feel it's very helpful to get down to your ideal body weight, which means if you've had a previous pregnancy, try to lose that extra weight that you gained. And if you happen to be a little bit overweight, then try to get to, a BMI of between 20 and 25. Easier said than done, but, start getting into the habit of eating a healthy, balanced diet, starting a aerobic type exercise regimen that you can actually carry through the entire pregnancy. And if you could avoid excessive weight gain in pregnancy, then it will lower your risk of certain complications like high blood pressure and diabetes, and it'll help prevent the baby from getting too big, which will lower the risk of C-section. But even if it's a natural delivery, a bigger baby has a higher chance of causing more tears and the shoulders to get stuck. And if you exercise in pregnancy, the aerobic type, like it could just be like brisk walking or swimming or low impact aerobics, you feel better. You have less back pain, there's less constipation. But I found that people who exercise regularly tend to go into labor more commonly than people who don't, and are less likely to need to be induced. And plus, their labors tend to be faster and less painful. And if they've been exercising, they're stronger, they're more flexible, they have more endurance. And sometimes when it's time to push out the baby, if you're strong, you're not going to tire after a half hour, and you might need to push for hours and be more successful. So that's one thing that's important, maybe the most important thing that you could do to lower your chances of ending up in a C-section. The other is more you're a doctor. And it's very important to choose a doctor that you feel comfortable with, that you can have conversations with and discuss your wishes, and is open to hearing what you prefer, but at the same time who's going to give you his or her recommendation. A lot of the success in a physician has to do with their training and their experience. So, some pregnancies are complicated. Like, for example, if somebody has a breech presentation, their baby's presenting where the head is up and the bottom or the feet are low. So that's not an automatic C-section. We have a procedure that we call an external cephalic version, that is generally done in the hospital, usually under epidural, where we try to turn the baby from the outside. And in the right hands, you can have a success rate of up to 80%, and the baby could end up being head first. What about in somebody who's had a previous C-section? There was once an adage, once a C-section, always a C-section, but that's not true. In fact, if you've had one C-section, I would say the second pregnancy is maybe the most important, because if you succeed, then your stats aren't so bad. You have one C-section and one natural. Maybe the rest of them will be natural. But if the second one is yet another C-section, it really makes it that much harder for the third one to be delivered naturally. So there's something called a VBAC, a vaginal birth after cesarean, where, again, depending on your doctor's training and skill and experience, the success rates could also be up to about 80% successful. Another complicated pregnancy, what if somebody has twins? What if it's twins and the second baby is breech? No, even that's not an automatic C-section. You could try. Just a couple of weeks ago, we had somebody with that scenario, and the first one came out naturally, was head first, and sure enough, the second one stayed breech. So there's something that we have, it's called the total breech extraction. And it's actually kind of fun. You grab the baby's feet and you pull it down. Somehow, the hospitals don't seem to object to delivering the second twin breech vaginally. They seem to object to singletons presenting as breech to try to deliver them naturally. But so these are some of the things that we can do in complicated pregnancy. But in reality, in my experience, I've found that most of the C-sections that are preventable actually happen in normal pregnancies and what I consider normal labors. So some of the points that I'd like to bring up is, obviously there's always exceptions and every case is a little different, but in general, people who go into natural labor will have a better chance of delivering naturally than people who need to be induced. Now, of course, there are some people that need to be induced for medical reasons, like if the fluid is low, or if the blood pressure is high, or if the baby's growth restricted. But I think it's a mistake, especially for first-timers, people with their first babies, especially if their cervix is not ready yet, it's not ripe, to try to force an induction, because you may never get to that point. If somebody's in labor, they're starting in labor already. If somebody is trying to get induced, you could spend hours and hours and hours, and sometimes never even achieve that step one of being in labor. And there is such a thing that we have, it's called a failed induction. So, I feel like, don't nudge your doctor about, getting them to agree to induce you. I know it's uncomfortable to be pregnant in the 9th month. It's hard to sleep. It's hard to get comfortable. But patience is a virtue. I feel like the chance of success are better if you wait until labor happens naturally. Along the same lines as when you do go into labor, even early labor is painful. That doesn't mean you have to rush to the hospital and stay. If you're in early labor, usually I tell my first timers, wait until your contractions are at least 4 minutes apart, lasting a minute. And then when you get to the hospital, I usually try to not admit them unless they're at least 3 centimeters dilated. I mean, there's always exceptions, because ultimately they'll take an epidural, they may end up essentially getting induced. Another thing that's important is I always tell my patients, before you go to the hospital, make sure that you ate well and that you drank well. Just like you'll feel better if you're not fasting, guess what? Your baby will perform better also in labor if you ate well and drank well. We see patterns in the baby's heart rate that usually tell us, okay, maybe the mother's a little dehydrated. the labor is potentially a big stress on any baby, and even the baby needs a little hydration, a little, sugar in its blood. So that's one thing. Even in labor, I usually allow my patients to eat and drink up until they get to be about 6 centimeters. That's one thing. What about epidural? That's a big question. I get that all the time. Should I take an epidural? So an epidural can be your friend. It could also be your enemy. If you take it too early, again, this is my experience, I find that if you're not in labor, it's potentially going to slow down your contractions. And then you're going to end up with possibly your physician recommending Pitocin or rupturing the membranes. And each of those things carries a risk. Sometimes you end up with a little too much Pitocin, you have too much contractions, the baby doesn't like it. Or you break the water, now there's no cushion around the umbilical cord, the baby's heart rate goes down and everybody gets panicky. Now you're just one step closer to a C-section. So I would say, wait to get the epidural until you're really in active labor. It helps relax your pelvic muscles. The nurse can place a urine catheter to keep your bladder empty at all times. And that actually will allow the baby to descend into the birth canal easier. Now, even if the water breaks and there's a pattern of the baby's heart rate going down and potential stress, there are other things that we can do. There's something called amnio infusion, where we introduce fluid back into the uterus. It creates a cushion around the umbilical cord, and that sometimes can prevent C-sections. One of the more common reasons C-sections are done now is because the baby's in stress. So that can sometimes relieve it. Another common reason for C-sections is lack of progress. So some of the things that you can do in labor that can help the baby progress a little bit is changing positions. It sounds simple. We have our nurses instruct the patients to turn to the left side, the right side, forward, backwards. Why does that help the baby settle into the pelvis? Well, an analogy I like to use is, you're opening up a bottle of wine, you got the corkscrew into the cork. What's easier, to pull the cork out straight or to kind of wiggle it side to side until it finally comes out? It's sort of the same idea, help the baby settle into the pelvis. In general, I don't like to rupture the membranes or give Pitocin as long as the patient's progressing. We now know that labor sometimes can take longer than we used to think, and patience is important. And if somebody's progressing even slow, I just let it happen. If they stop progressing, then you could talk about some of those things like Pitocin or rupturing the membranes. But we've all seen people end up with a C-section because they've been stuck at 4 centimeters for 2 hours. Well, we now know that some people are not in active labor at 4 centimeters, and if you wait an extra hour or two, lo and behold, they're 6, they're 8 centimeters. So patience is important. Another few things, and then I'll end. Sometimes the baby comes down in not the best position. We've heard of the posterior position where the baby's sunny side up. Yeah, I've seen C-sections because the baby's sunny side up, right? It's not fitting. So, it takes a little bit of knowledge, training, and skill to figure out the baby's position in the pelvis, but there's something called a manual rotation where you can try to turn the baby into the right position. And sometimes, we've all seen it, once the baby drops in the right position, the labor progresses quickly. What about, when do you start pushing? You get to 10 centimeters, you're fully dilated, you start pushing, right? So possibly. What I usually do is, when my patients get to around 9 or 10 centimeters, we do what's a test push. Now, if somebody's strong, if they have a lot of room in their pelvis, and they push, the baby comes down quickly, we start pushing, and that's the best thing, get the baby out. But some people, they don't do so well. They're numb from the epidural, they're not that strong. So there's something called delayed pushing or laboring down, where you allow the natural forces of the contractions to bring the baby down as low as possible. And usually during that time, we talk about possibly lowering the epidural so that they could feel the urge to push. I mean, if somebody's that numb, it may be hard for them to sense the urge to push. And I find that sometimes that's helpful to prevent them from tiring out and help them to push effectively. But sometimes you need to let patients push 1, 2, 3, even up to 4 hours. Sometimes they do that and they're so close. You know, they went through a long labor, they've been pushing, and you could practically see the baby's head, and then they just get tired. So what? Is that a reason to do a C-section? Not necessarily. Sometimes we can help people avoid C-sections and get them to deliver naturally if we offer a vacuum delivery or forceps delivery. Again, it has to be in somebody who's experienced and comfortable with it. But you know, these are some of the things that, you know, I can't reveal all my secrets, but you know, these are some of the things that you can take with you and be more knowledgeable and help you choose the right doctor for you, but also at the same time during the pregnancy and even during your labor, you can have discussions with your physician about things that might help you have a normal labor and a successful vaginal delivery. And I wish all of you, whoever wants to get pregnant, you should get pregnant at the right time and have healthy pregnancies and easy deliveries and healthy babies. And that's about it.
Thank you so much. Dr. Grazi, could I? Oh, yeah, go ahead.
I just want to put my academic hat on. First of all, Victor's an exceptional physician and a lot of experience with a lot of skill sets. But the academics, first of all, if men had to do this, we'd get the epidural right after conception. So I don't know why you guys wait so long. But if you look at the literature on some of these topics, which are very controversial in trying to study this, currently, they have not shown that getting an early epidural is associated with a higher C-section rate, but it does lead to a little bit of a higher risk for intervention, like breaking the water or Pitocin, so it may be the right thing for the right patient. Additionally, looking at some of these other skills, whether it's external cephalic version, second twin breech extraction, forceps, or vacuum, those are very important things that some physicians have and a lot don't have. And so you do want to find out, particularly if you're having a twin pregnancy, the skill sets of the people that are providing for your care. And then third, it would be induction of labor. That's actually become the most controversial. Traditionally, people were thought that inducing patients in labor was associated with a higher risk for C-section. Most of the recent data suggests that elective inductions between 39 to 40 weeks is not associated with an increased risk for C-section. In fact, it lowers the risk for C-section in subsets. But the caveat, as Victor said, is that depending on their cervical exam. So if somebody has a very firm, closed, long cervix, the doorway is not open a little bit, they may not be the right candidates. There's still a lot of literature that we have to tease out to figure that out. But inductions overall do not increase C-section rates and may actually lower C-section rates electively. But again, right candidates, we're still learning. There's a lot of papers being written on some of these controversial topics. But I didn't want you to walk away, again, clinical care, judgment with your doctor and patient is important, but there is data to address some of these controversial issues.
I just wanted to add very, very briefly about cervical ripening leading up to being full term and labor. And so there are things you can do, very, very minimal things that you can do, such as, again, the evidence for this is a little bit, plus or minus, but they're very low risk interventions. So you may have heard of things like herbal raspberry leaf tea. These herbal teas can soften the cervix, primrose oil supplements, even dates, medjool dates, a few a day. There is some evidence to show that they can soften the cervix. And I do see some of my pelvic floor people in the crowd, like Fortune Abadi, and so these are people who really focus on the pelvic floor, can help you as well in the weeks leading up to pushing and even postpartum as well for a lot of the pelvic floor issues. So there are active things that you can and should do in the last weeks of your pregnancy.
Thank you to this amazing panel. I hope you all learned as much as I did. And
one thing.
Yes, go ahead.
It's true in the ideal world, you can induce somebody and it's a straight line, but you know, what I know happens in my hospital and other hospitals is you're not alone with your patient. And there are now in hospitals nurses and safety officers, and they're there primarily to reduce the risk for the hospital. And there's a lot of difficulty in getting people induced and delivered. So you may want to induce somebody and get them delivered, but you may have a nurse that gets very panicky the first moment she sees the baby's heart rate go down and turns off the Pitocin. Or you may have a safety officer that walks in and says, when are you doing the C-section? So that has to be put into the equation of the success of an induction. That, you know, it doesn't always go the way you want it because you have other players that prevent you from having a successful induction. So I factor that into why overall I tend to not recommend induction in patients. But of course, yeah, if somebody has a ripe cervix and it's their third pregnancy, and I agree that that's probably an extremely low risk of failure. But you know, it's multifactorial, and exactly, every case is different.
Thank you, everybody. Thank you to this amazing panel. I hope you all enjoyed. Please reach out to SBH Fertility for anything you may need, and don't bother them too much.